to Palamasi. Yeah. Good morning, folks. It is 8 o'clock on the dot. Before we officially start, please allow me to give a moment of silence for self-reflection, and the moment starts now. Thank you very much. Members, thank you for making the time to attend to this annual report meeting. Minister, to you and your team as well. To the members of the public, welcome. Those who are online and those who have joined us in the chambers. I wish everybody a fruitful meeting for today, one of the most important meetings of my life, especially. And hopefully we will carry the burden and we'll carry the cross. And I wish everybody a fruitful engagement. And I'm going to allow for ourselves to introduce the members, and then I'm going to come to you, Minister, to you and your team. I'm Emery Boyson. I'm the chairperson of the Standing Committee for Health and Wellness. And I'm going to come towards my left.
Morning, Chair. I'm Leon van Beek, a member of the Health Committee and also Public Accounts Committee later today. Good morning to Minister, HOD, and to the team of officials and to the other honourable members as well.
Morning, Chair, Minister, HOD, and all the other officials. I'm Donita Stevens, and I'm a member of this committee.
Good morning, Chair, Minister, HOD, and team. My name is Rachel van Vogel, and I'm a member of this committee.
Good morning, everybody. I'm Benedicta van Minnen, and I'm a member of this committee.
Good morning, everyone. I'm Thomas Walters, a member of this committee. Thanks.
Are there any members online? I'm giving an opportunity to them.
Greetings to all. My name is Dwayne Jacobs. I'm a member of this committee.
Thank you, member. I don't know if there are any other members online. If not, Minister, I'm going to give over to you.
Good morning, Honourable Chair, and good morning to the honourable members, as well as to the Health and Wellness team. We're very happy to be here this morning in presenting our annual report. I'll ask each member that's here from the department to introduce themselves and their title. Thank you.
Thank you, Minister. HOD.
Good morning, Chairperson. Good morning, honourable members, members of the public, and to all my colleagues. I'm Keith Clutie. I'm the head of Department of Health and Wellness. Thank you.
Morning, Chair and members. I'm Sadiq Karim. I'm the Chief of Operations.
Morning, members. My name is Anda Ngosi. I'm the Chief Director Strategy. Thank you.
Good morning, members. I'm Leslie Shand, Deputy Director in Health Intelligence.
Good morning, Honourable Chair and Honourable members. My name is Laura Angeletti Dutwe. I'm the Chief Director for Facility Infrastructure Management.
Good morning, Chair and Honourable members. I'm Glenn Carrick. I'm the Chief Director of Finance.
Good morning. I'm Glenys Denica, responsible for collating the annual report.
Good morning. I'm Lauren Popman, graduate intern Health Intelligence. Good morning, everyone. I'm Salih Aziz, Public Health Registrar in Rural Health Services.
Good morning, Chair, honourable members. I'm Peter Smith, Department of Health, People Management.
Morning, Chairperson and honourable members and colleagues. I'm Bernadette Aris. I'm the Chief Director, People Management.
Morning, Chair and honourable members. Juanita Arendse, Chief Director, Emergency and Clinical Services Support.
Good morning, Chair, honourable members. I'm Desiree Mohane, Director for Management, Accounting and Finance.
Good morning, honourable members. My name is Hassan Mohammed. I am a public health medicine specialist working at Metro Health Services. Thank you.
Good morning, Chair and everyone. I'm Patty Alkes. I'm the Acting Chief Director for Metro Health Services.
Dr. Clotaine.
Chairperson, our Head of Corporate Services and our Chief Financial Officer, Mr. Simon Kay, is unfortunately with a family illness in Port Elizabeth, but he's joined us online.
Thank you for that.
Morning, Chair.
Morning.
Morning, Chair. Morning, members. Morning, Minister. Morning, colleagues.
Are there any other officials online? Doesn't look like it. I'll give an opportunity to the two pretty ladies at the back on my left-hand side. I'll start with the lady in pink.
Good morning, Chair and members of the Portfolio Committee and members, officials of the Department of Health and Wellness. I'm Damaris Kiewicz from the University of the Western Cape, the Community Liaison Officer.
Welcome, Mrs. Kiewicz.
Morning, Chair, members and members of the department. Susan Smith, I'm from the Minister's Office.
Thank you for that. Are there any other members of the public online? Doesn't look like it. Thank you, members, and once again, thank you to the officials, Minister and the HOD. We all know the purpose of this meeting is to interrogate the annual report, but please, folks, allow me, before I give over to the Minister and to the HOD to do some introductory remarks, I have some introductory remarks of my own. Members, for the benefit of those who are new in the Parliament, new in this committee, including myself, this is an eye-opener for me. The first time I started to engage with the Department of Health was during COVID-19. And Dr. Klute, I must confess, at that time, we all just saw health as being health and health doing what health is supposed to do. Until I had my meeting with the Auditor General's office. And what came out in that meeting was an eye-opener for me, members, and to the professionals. An eye-opener in the sense that this department really punches above its weight. With all the challenges, with all the financial shortages and whatever cuts from national department, this department is the beacon, not just for the province, not just for South Africa, but for Africa. This is the best health department on the continent. And I never realized that until I had that meeting with the AG's office. And I must confess, colleagues, I'm looking at this department with a very, very different view. And I must also say that we are all filling very, very big shoes. And colleagues, members, I think when we have time, and it's a discussion which also came out with the AG, is that we need to look on how can this be replicated to all the other provinces in South Africa and also to the continent. This is indeed a yardstick for the continent. And I must say, Minister, I am nervous for my own part. I'm nervous for your part. I'm nervous for the members here, because how do we maintain that with all the challenges which are lying in front of us? But I am optimistic, and I think that You guys have gone through the test, Dr. Cloete, Minister, and hopefully we'll keep it together under very difficult circumstances. And with that said, Minister, I'm going to give over to you to do some opening remarks, and probably to you, Dr. Cloete, and we'll carry the wagon together. Over to you, Minister. Thank you.
Thank you very much, Mr. Chair, for those very encouraging remarks. This morning, we'll be presenting the 23-24 financial year annual report to the committee. I'd like to begin by expressing my thanks to my predecessor, Dr. Mbombo, who was the executive authority in the period under review. This was, of course, the year that the fiscal emergency hit South Africa and the consequences start to become evident. It was also a time of severe load shedding and natural disasters and flooding. But in spite of all these difficulties, it's clear that the Department of Health and Wellness has remained stable. It achieved yet another clean audit, its sixth one. It remained an innovator, and I'm very happy that our double robotic device called Georgie appears on the front cover of the annual report. The department also remained a very good partner, and you'll see partnerships reflected throughout the annual report. So the department in this year under review has worked very hard to keep the course, no matter how turbulent the waters. And I must express my sincere gratitude to the men and women who day in and day out, under very difficult circumstances, tirelessly deliver health and wellness in the Western Cape. And so with that as some introductory remarks, I look forward to taking questions from the committee as we move through the report. Thank you.
Thank you, Minister. HOD.
Thank you, Chairperson. Thank you for your words and a very kind acknowledgement of what this health system in the Western Cape actually represents. When I assumed as an head of department on the 1st of April 2020, I understood the magnitude of taking responsibility as the accounting officer for this department. I understood the history. I understood what was facing the department at the time. And I understood that what is required is to navigate this department through what at that time was uncertain waters. I'm standing here with you today and in this committee because we've navigated that last 5 years with previous committee as a new incoming committee to just humbly say that I'm here with a group of people that during this time has held this, what we call the common good for the citizens, not only of this province, for the country, and as you say, for the continent. We don't take this responsibility lightly. It's entrusted to us. We view it and carry it as custodians and a stewardship and give it the due care that it deserves. So when we stand here with you, having navigated this period of turbulence, we do stand here today to report on this period of time where, in our estimation, even since COVID, the past year represents the biggest turbulence that the healthcare system has faced. And to be able to stand here and report on the performance, we will do it honestly, we will do it with integrity, and we'll do it with humility. Because only through honest reflection with the standing committee and standing to account on behalf of the people can we do justice to this. So it's in that spirit that all of us are here with you today. Thank you so much.
Thank you, HOD. Members, may I make a proposal? I believe by now we've got some experience in going through this committee's annual report. May I propose that we take it in parts? When we're going to interrogate and ask questions or make comments, we take it in parts. But if the members can please then refer to the pages that you are referring to in terms of asking questions or making comments. I would then now open up the opportunity to the members to comment or react to the opening remarks of the minister as well as the HOD. And then after that, then we can then go to the specific parts. The floor is open. Going once, going twice. I see that there are no remarks on the opening remarks of the HOD and the Minister. Members, can we then go straight into the business of the day in terms of interrogating the report? And please refer to the pages in asking the questions or making the comments. The floor is open. All right. I am now on part A, pages 4 to 21. And please, can we stick within the parameters so that we don't outpace the others? We'll take it part by part and page by page in terms of asking the questions. I'm now tabling part A, starting from pages 4 to pages 21. Member Van Gogh, is that your hand? Member Van Gogh, you may go first.
Thank you, Chairperson. And once again, good morning to the MEC and my favorite HOD and my favorite Deputy Director, Dr. Karim. I call them favorites because those are the engine of the organization, of the institution. Chair, and on all the team. Chair, let me at least welcome the fact that we are here and we do have the team here. And I think this is not a session to fight. We are here to review your work of your annual report and to learn about the work you have done of accomplished over the past year. And our role is not to criticize per se, but for the sake of criticism, but it's to support you in overcoming challenges and enhancing the service you provide to ensure that our people get the service that they do deserve. I know the MEC is new, Chair, and when I went through the annual report on page 4, it's in this in the last term, the term before that, normally the practice was that the forward will be done by the current MEC. And I look at the annual report, I see our former minister, Dr. Mbomo. And now, would you please receive, can you please give clarification on why the department has provided the forward from the former MEC, and how can we hold her accountable as the new MEC if it comes to the forward? So if I can get just that understanding why we still have our former MEC on when it comes to our forward in the annual report. Then, Chair, on page 4, point of reference that in response we implemented widespread cost-cutting measures, including renegotiating contracts with suppliers and temporary freezing new hires. So I want to understand, could the department please provide more detail when it comes to these cost-cutting measures? Specifically, I want to understand which programs were affected and what goods and services these measures were applied to. And also, my primary concern is how these decisions will impact poor communities in rural areas and working class townships. Additionally, Chair, could the department also provide details on the number of positions that have been frozen in this duration? Then lastly, Chair, on that point, the department's decision to freeze posts is similar to, for me, it's similar to what the WCED have done. And I want to understand why does the department consistently target vacancies as a means of cutting costs? Is that a strategy aligned with its ongoing efforts to reduce the public sector wage bill since it took power in the Western Cape? Then on page 4, Chair, the second sentence of third row, a point of reference that we launched initiatives such as the rollout of inventors at PHC facilities in our rural districts. Could the Department of the HOD provide details of all the PHCs that were provided with these inventors? Additionally, what was the total cost of this initiative and the names of the service providers who were awarded the tender? And lastly, what was the tender advertised? Was the tender advertised through an open process? I will park there, Chair, for now. Thank you.
Thank you, Member. Before I give over to Member Van Minen, we've been joined by another member online. Member, can you just state your details, please?
Good morning, Chair. Good morning to the department and to the MEC. My name is Ayanda Barnes. Thank you, Chair.
Thank you, Member Barnes. We acknowledge you. Member Van Minen.
Thank you very much. I fully appreciate the difficulties that the department has faced in the last couple of years with the fiscal crisis, with the in-year budget cuts. But just in terms of the organogram, I see there are 5 vacancies. This is pages 20 and 21. 5 vacancies, including such roles as the director of the Overberg. And I just want to know, is there a policy to use the vacancy budget to repurpose it, or are there moves to actually fill these posts? And if so, what the sort of timeline is? Because these are, relatively, well, these are senior posts, and I just want to know how the department's approaching that. Thank you.
Thank you, Member. Member Van Wyk.
Thanks, Chair. The one number that sort of sticks in my head, or the one ratio, is the number of contacts that you have per year within your hospitals. And I was now looking through the book here to try and find where I'd noted it. And I knew it was somewhere 11. I see 11.9 million. And if we've got a population of 7.4.
What page is that, Member?
This is on page 24. In the middle of the page under primary care is where that number is. It comes out to about 1.5. I haven't actually checked the 1.5 incidents. And we recently did a site visit to Oudtshoorn Hospital, and they showed us some figures there, which the theory was it was probably should be around about 1.5, but because of some of the census numbers, because they believe there's bigger population, using the lower level that census is doing, that number tended to be higher. Now, I don't know if you've got any, I guess you look at some of those numbers, because that also then determines probably the number, the service. And I don't know if you've got any view then on whether the 1.5 is high relative to other parts of the world. And then how does that impact then on your resources in terms of your staffing and to operate effectively? So I suppose that's the one issue there that I have noted. What we've also heard, for instance, on the emergency service, the medical services, in other words, your ambulances, that there appears to be a bit of a shortage in that we are not quite fully equipped there. So possibly if you could comment on a number of those issues. Thanks.
Thank you, members. Minister, over to you and your team.
Thank you, Chair and members. On the question regarding the forward, the annual reports have particular deadlines for each of the deliverables that make up the annual report. As the member will know, we had elections in late May, and the legislature was only constituted in June, and the cabinet was only then announced on that day in mid-June, by which time the forward had already been produced and had to be submitted for the different technical timelines for the production of the annual report. So that is the reason why the forward was still under the care of my predecessor and therefore appears in that way in the annual report. But for the next annual report, then I will be writing the forward for the 24-25 financial year.
Dr. Klute.
Thank you, Chairperson. So I think the questions from Member Windvogel, it's got to do with the cost savings and the two parts to the cost savings. One is post, the other one is the renegotiation of contracts. But I think the key point you're asking is what decisions have been made, how the decision made, and how does it affect poor and rural communities, if I understand that correctly. So just to give you the picture, in the adjustment estimate in November 2023, November 23, right? Adjustment estimate. Yeah. In the adjustment estimate, we came to the portfolio committee that time to say we enter with a budget for 23-24 that does not accommodate the increase that was negotiated for the salaries. So we went into the year 23-24 with a deficit of 1 billion rand. Because we signed off the budget, tabled the budget, and there was no clarity of where the money was going to come from for the increase or the negotiated salaries. When the adjustment estimate process started, now we worked on the assumption, because what happens normally, if things are negotiated outside the realm of the control of the accounting officer of any one department, the principle is National Treasury will make good on any additional things on top that's outside the bargaining chamber. It became clear to us in the adjustment estimate that we only received 78% of that. So all of a sudden, we were into October. We got wind that the money we're going to get is not going to cover the salaries. So we were then in October, November, facing a 700 million shortfall until March 2024. Now that is a space of 5 months. To make good on 700 million shortfall, we had no other option but to put a hold on the filling of posts at that time. And when you say, and very clear, Member Windvogel, we prefer to have line of sight. We prefer not to have to make decisions like that with 5 months of the financial year left. I'll explain the difference with the year we're in, because in the year we're in, we have line of sight and we can make decisions 12 months in advance. But with that situation, we had 5 months. I only have two options. You continue to fill posts, you continue to spend money exactly the way you're spending it, and you run out of money, which we then had that by the 15th of January. What does that mean? You don't pay any accounts to anybody. Our salaries of our staff will not be paid. So basically from January till March, we are not in a position to pay anything. Now, either we take that or we say we have to continue keeping the department financially functioning until March and not run out of money. That was the stark reality we face. What we did is any post that was vacant at that point could not be proceeded with in the normal process. So we then, and we have a very decentralized system. Any manager of any hospital, any district can fill the post because we've given them something called the approved post list, and they can fill the post with the money that they have. All of a sudden, we took that delegation and we lifted it to Dr. Karim and to Mr. K. And for those 4 months, you could only fill the post if there was maneuverability within that reduced budget envelope. So we did fill some posts, but it was a small minority of posts where something was catastrophically going to come to an end, and there was a little bit of decisions. But I literally remember Dr. Karim, Mr. K, had to go through a rigorous process of saying 500 posts wants to be filled. People want to fill 500 posts across the department. We can only fill 7. How are you going to make those decisions? It was not an easy time, Member Van Vogel. We did it for the purpose of the financial sustainability of the department. We had conversations with our clinicians. You will recall clinicians went into the media and say this is going to have a detrimental impact from Groote Schuur Hospital and Tygerberg Hospital all the way to primary care. That was the impact. We don't make that a small issue. For us, that was a big impact. That's why I call it the biggest impact, even bigger than COVID, in my estimation, as the manager of the overseeing accounting officer of this. We did that in a way to say to people, that is our reality. So your question is, that results, because what we had to do is we then had to adjust what is called our approved post list. Our approved post list is, these are the posts at the beginning of a year, which we have money for. Then you have your money and you can fill whichever post, you can exchange if there's different priorities. This process forced us to adjust our approved post list. The bottom line of the approved post list is we had lost 194, was it? Glenn, is that correct? 194? Just want to get that figure right.
I think we had to cut it. It equated to about 450 posts, if my memory connects.
50.
Yeah. The number was 800 or 900 million that we had to realign.
So it's about between 400 and 500 posts that we lost in that process. And this is now only reconciling it afterwards, Member Van Vogel, because at the moment, at that point in time, we had an approved post list for which we don't have money. And we just pulled up the brakes. We could only fill a handful of posts. When we then got, remember now we have to meet the end of March target. And then in February only do we get confirmation of the budget for the year that we're in, which is 24-25. So we have to reconcile what we can fill up until the end of March, because everything you fill up to the end of March, you must have money for the next 12 months at least, in terms of warm bodies. And that reconciliation was then 400, I think it was about 150.
Sorry, Dr. Krichter, can I just make a correction there? Sorry, between the MTech coming up and this meeting, I've mixed numbers around. We reduced our APL by 489 million, which equated to 954 posts. So, that was the other way around.
Sorry, so I was right. Sorry.
Yeah, you were right.
I was worried that he was correcting me. It is 954 posts. It was 450 million rand. It is 954 posts. So that is what this net impact of this was. That is not it's not a small matter. It's a big matter. 954 posts. This whole process that I tried to explain to you, which was we had limited line of sight in October last year when we put the brakes on. Because, and you asked, why do we target vacant posts? Well, that's the bodies for which we're not paying salaries for yet. That's the only way, and it's blunt, and it's unfair, and it causes untold harm to the system. That is the situation. So if there's a critical post of somebody that is a clinical nurse practitioner in Oudtshoorn that had to be filled, it could not be filled. As opposed to a critical post in Groote Schuur and the Red Cross. There was no distinction in our mind made between all of those, because that's the blunt tool that we have at our disposal. So just to point it out to you, Member Van Vogel, the healthcare system in its entirety was affected. Whether you were in a small town or whether you were in a big hospital, it was all affected because everybody had vacant posts. I'm just giving you the total in hindsight impact of that period, which was in our funded envelope, having to lose 954 posts. Now, what does that mean for how Dr. Karim and Mr. K handled that situation. They had to do it to say no vacancies can be filled, but there had to be that people can say, well, if we do not fill that post, an entire service comes to a standstill. That we couldn't allow. So there were, of the critical posts, all posts are critical. Of the critical posts, there were hypercritical posts. Of the hypercritical posts, there are essential posts that you cannot, because then an entire service comes to an end. That's the kind of difficult calls they were caught in between November, December, January, and March, which is probably the most unpleasant time for Dr. Karim. He's worked in our department for I don't know how many years. Like probably 30 years. Like me, 30 years. Probably the most unpleasant time in his tenure in this department to be able to do that. So when we say it is a big impact, that's the impact. We're not saying it's a big impact from where it had an impact on us. The people that had the greatest impact on was our frontline staff, because the patient didn't get less. The people that need care didn't get less. The people that require an ambulance didn't get less. All of that continued. And remember, now we're going into, and this is young doctors qualifying, looking for a job. They couldn't find a job. New people coming in to become trainees for specialists. They couldn't find it. And at that same time, people were saying, well, other provinces are offering jobs and people taking it. That is all the things we face. That is heavy. It's difficult to manage. The biggest impact is the people on the front line that was left. Where there were 6 people, now there's 4, now there's 5. They must do the same workload or slightly more. And unfortunately, Member Benvogel, that was everywhere in the province. From primary care, everywhere across the area. But I hope that answers your question, because the 954 is the total outcome of the 500 million that we didn't have for posts. When it comes to renegotiation of contracts, now, again, we have been working slowly. And part of why, Chairperson, the point you can make is that if we had to do that, so the one thing is it's massive and it's really a big thing. The other thing to look at it, we were able to do it. Let me just think about that for a minute, Chairperson. That we were able to say we pulled the delegation up to 2 people, and it resulted in posts not being filled. And it resulted in us being able to come within budget, resulted in us being sitting here with you to still have a clean audit through all of that. It just means that our system has been prepared to do something as drastic as that. And that is the second part about the renegotiating contracts. When we had to then renegotiate the contracts, because the point was every contract had escalating prices associated with it. Every contract. And you can understand the people that supply the stuff to us, they must import it, they must get it. It's above inflation. So everybody comes back. But our team then basically said with, let's call it purchasing power and volume, that there's not a single increase on a contract that we will automatically only accept. The team went into negotiating every single contract with every single supplier. And even if it is a 0.5% reduction, a 2% reduction, a 1% reduction. And a lot of the contractors actually did it because they have predictable work from us. You get a contract with our department, you know you're going to get your stuff, but you also know you're going to get paid. So many people, although it's difficult for them, accept it because of uncertainty elsewhere, that they would be willing to negotiate the lower prices because at least they know it's volumes and at least they know they're going to get the prices. So again, Member Benvogel, that is just testament to how well the system functions. Notwithstanding wobbles in that space as well, which was the whole security contract. Wobbles around other things, which is cleaning contracts. So all of that comes together in one perfect storm between November last year and the end of the financial year, March, which this reporting period is about. When it comes to the inverters, Dr. Angeleti du Toit, this is one of, I probably say, one of the shining lights of our department last year. Because if I dial you back to where we were, load shedding and rolling load shedding was a reality, and it was severe at that point in time. The load shedding relief only came probably in February or March of this 1 month in this financial year. In the middle of this November, we were still eating load shedding all the time. And Dr. Angeleti du Toit and her team negotiated being able to go to primary care facilities. And the idea there was, if we had to put in inverters in facilities, start with the ones that is the smallest and the most remote. In hindsight, the best possible decision we could have taken. Because easily would have been, let's go to 2 or 3 big facilities, and all budget we had would have bought us maybe half buying the price with solar solution in 2 or 3 big hospitals. It would have gotten lost in all of that. But starting with the smallest facility from the outside in, and then doing it in a way that was cost effective, and there's a whole lot of process around the who got it, what's the tender, and that in itself was scrutiny of the Auditor General, because we leveraged off a very good process to be able to purchase that. So I'm going to allow Dr. Angeleti du Toit just to give that specific detail, and if need be, we can follow up. Dr. Angeleti du Toit.
Yeah, thank you, HOD. Okay, so we did the installation of the hybrid solar, that means inverters plus batteries, to 47 clinics in the rural area. I will make available to the committee the list of the clinics. Our clinics, they don't have generators because they are not 24 hours. So for that reason, there was an urgency to do it as quick as possible. We were dealing with stage 6 at that time. We spent a total amount of 25 million, and Rionet was the contractor. The contractor was appointed by the Department of Infrastructure. We did we asked permission to the Department of Infrastructure to use their contractor, and we were able to do it as quick as possible. We could do it. Thank you.
Thank you, Dr. Angeleti du Toit. Member Van Minen, your question is on the 5 vacancies. There's a process to fill each one of the 5 vacancies. So actually, the director Overberg, the post has some subsequently been filled. Let me just get this right. My own glasses are not with me now. The director information technology, the person is assuming duty on the 1st of December. The director infrastructure program delivery, the person has commenced duty, Laura, on in May. Was it May? 1st of August. The director people development, we went through a recruitment process. We couldn't find a suitable candidate, but subsequently we're about to confirm that we have an internal relocation of somebody, and we will fill that post. And then that leaves us with 1 post, which is the director supply chain. We've already gone through 1 round of recruitment, couldn't find a suitable place, and we've got shortlisting for the next round. So but by all intents and purposes, all those posts need to be filled, and it is the leanest structure. When we orientated Minister Wenger on this is the leanest structure of any health department in the country. And because it's lean, every single post counts, and we have to have each person filled. There's no slack in the senior management positions. Then Member Van Wyk, I think the question you're asking is a crucial question. The 11.9, the context that you're talking about is primary care. And the primary care context, it's a whole complicated thing behind this 11.9. But these are the people that, according to a definition that is tracked by the National Department, is the people that come into our primary care facilities. There's a whole lot of people since COVID that has contact with our health services but doesn't come to the primary care facility. One of our challenges with National Treasury is they take this measure and they allocate across the provinces according to this measure. Now we know there's an additional 8 million contacts outside of that 11 million. That is a home-based carer going to somebody's home. It's people picking up their medication at the site in the church that's not here. It's us going to schools. It's all of those. So we work on about 20 million contacts. Now, you rightfully saying our population is 6 million. So the issue is, what is a fair utilization rate? And you can then break it down, that context, to an area like a sub-district in Oudtshoorn. And then we look at with 32 sub-districts. The question is the utilization per population high in one? Is the utilization per population low in another one? What is fair? We have something called a district health expenditure review that we've done quite meticulously over the years. Professor Mohammed behind me is one of the people that really analyzed that in detail because it informs the district plans. We can tell you that the utilization across this province is reasonably fair compared to benchmarks. We've even gone further to track that utilization down to understanding, because we have data about individual people by their number and their name, we can track whether the average of 3 per population to the visits, whether that is everybody. We know that there's about 5% of people that comes 12 times. Some people even come 20 times, and others only comes once, and others don't come. So we have that level of detail. But your question is right. What is a fair utilization for the people that we have? And the same would go fair utilization for ambulance deployment or ambulance calls in that geographic area. So we very much look at our planning in terms of fairness of our distribution of our resources, whether there's a fair utilization. Now, the one thing that complicates that is that not everybody in every geographic area has the same burden of disease. So we have to skew it for fairness, that there are more disease in certain areas than others. So it can't just be equal. You have to then, and that's what we call an equity-based resourcing approach. But thank you for that question. Thank you, Chairperson.
Thank you, HOD. Thank you, Minister. Any follow-ups, members? Member van Vogel?
Yeah, thanks for the explanation, HOD. Perhaps English is not my mother tongue. Perhaps I miss it somehow, but the minister in a forward, she mentioned about this page 4, second sentence, she mentioned about the inventors at PHC's facilities in our rural district. Can she please explain to us that which PHCs that were provided with these inventors, and additional, what was the total cost of this initiative? Yeah.
HOD?
Sorry.
And the minister's forward.
So sorry, Minister, Member Van Vogel, that's exactly what Dr. Angeletti de Tooy did. And she did say it was 47 primary care facilities. She said it was a battery with an inverter. And she said the total cost was?
Which PhD?
He said a list of
40 which?
And she will give the list if required. Yeah.
There's a long list.
I can give you the list.
You need to forward that then to us. Yeah.
We will forward the list.
Yeah.
It's 25 million is the total cost.
The cost is?
25 million. Rionet.
HOD, member, you satisfied?
No, I'm.
Okay, thank you. Now we're still on the first part. I'll hear from you when you guys are satisfied, and then we'll move on. You may shoot.
Oh, I see there's a hand up there. Sorry.
All right, Member Barnes, we see your hand. Can we give over to you, Member Barnes, and after you, it will be Member Jacobs, and then we'll come back to you, Member Van Vogel. Member Barnes?
Thank you. Thank you, Chair. Thank you, Chair. I don't know if I'm allowed to make a follow-up question. I entered the time the HOD was explaining the 1 billion deficit that they started on. So I would like to make a follow-up on that based on my questions that I prepared on page 9. One would continue to read on discontinued activities where they speak on the scaling down or the scaling down on the Metro Health Services, and also on the part of the Salt River Forensic Laboratory that has been closed earlier as anticipated in October 2023. That's all on page 29. Now, Chair, my follow-up on that 1 billion deficit is that one would want to know the impact. One is not getting a clear sense of the impact it has carried with this 1 billion. And also, Chair, I think I've been part of this committee for quite some time. One hasn't seen the budget increasing. Are there any specific plans made to accommodate critical issues? And even so, one can see that the budget is constantly come to the meeting and here there is a budget problem, but the reality is the services are needed. So what plans are made? As one cannot say that we are hoping for an increase of budget. Is there a way that the department is thinking around working the issues, as one is saying that one is more concerned on the impact that is carrying, and yeah, mine would be more around that. There is a deficit, and from where I am and the experience that I've carried being part of this committee, it's very seldom that you hear that, no, the budget is fine again. What is the department and the MEC planning when they're sitting down and saying that, okay, this is what's the problem? This is how we think to address it in moving forward. I just wanted to make a follow-up on that, because one realized that critical issues at some point become neglected. Thank you very much, Chair.
Thank you, Member Jacobs.
Thank you, Mr. Chair. Yeah, Mr. Chair, greetings to all in the house. Mr. Chair, I just want to go back to page 7 now. I just need to understand there with the under expenditure. I don't know, maybe I have a clean brain, but I just want some clarity on this. So I see there that there's a lot of money that is being underspent, no? And then when we go to page 219, we'll see there that the current payments is for compensation of employees and goods and services. Now, what I want to know is, with all the vacant posts, it was said by the HOD that they needed more money, more funding. I want to know, is that money that is still underspent, is that to cover that vacant post? Or are we saying we need more money to cover that vacant post? I just need some clarity on that, please. Thank you.
Member Van Vogel.
Thank you, Chair. Chair, mine is then on the report of the accounting officer. The HOD and his team took over the MEC's job. So now I'm on his input or report. He mentioned in paragraph 1, page 5, point of reference, the end of the 2023-24 financial year marks 48 months since the onset of COVID-19 pandemic. The COVID pandemic took an emotional toll on all of us. Many lost loved ones and livelihoods, and we are here today because of the selflessness and dedication of our healthcare workers, who really risk their lives daily while working in challenging and unsafe conditions. And some of them lost their lives. And I think I'm well known for this point. That could the department share what action have been taken to express gratitude to our healthcare workers for their extraordinary efforts during the pandemic, and to honor the sacrifice of those who lost their lives in line of duty? I know there was a promise made somehow, somewhere, when it comes to that. So I want to get the understanding, where are we now? Then, Chair, on page 5 also, under the report of the accounting officer, we started a financial year with our 6th consecutive clean audit, a remarkable achievement that speaks to our commitment to good governance. While we commend the department for achieving its 6th consecutive clean audit and hope it can maintain such standard of financial management. However, it is unfortunate that such strong financial performance does not really speak or translate into quality healthcare for the underserved population in the farming community, on the rural outskirts of the province, in the Cape Flats. Therefore, could the department elaborate on what measures it is implementing to ensure that these clean audits do not just end there, but are also translated into improved healthcare service for the majority of residents, poor working class community. What is the point of celebrating clean audit when Ansari spent 3 days sleeping on the floor while waiting for an ambulance from Beaufort West? And Betty spent 2 days sleeping on the chair in Mitchell's Parade without getting any care from a doctor. Or we have a patient from a farm area in Naisna Hospital waiting 3 days without seeing any medical help. And then lastly, Chair, I think Dr. Keith is aware of this incident, and I think Dr. Kluti, we lost a young girl, I think, I'm not sure, was it last year, somewhere last year, due to transportation issues preventing her from reaching Tygerberg Hospital. I think she was 9 or 10 years. It means that a farm worker needs to walk 10, 12, 15, 20 kilometers to get to a point where she can make an appointment. Then when they arrive there, there's no space. And so it went on. Every time there's no space, we lost that child. It was heartbreaking. I think Dr. Kluti knows. We are sitting with the same problem at the moment. I've sent it to Dr. Keith with also a farm worker, still with this type of same problem. So how do you connect this? Because when we speak about clean audits, when we want to celebrate that, how do it relate to service delivery? That's what I want to see. When we say, yes, we have done it, is Antisari, is there something that we can say, Antisari, we save Antisari's life? We saved that young girl's life. We are going to save this one. I hope so. We are going to save the one. I sent an email to Dr. Karim. So how we will save that life? And it will not be too late like the one in 2023. So Chair, that's on the accounting officer. And then Chair, also on page 5, second sentence of last paragraph. I just want to check whether the Chair whether the department, if they can provide, because on the point of reference, they mentioned that from a cultural and leadership perspective, our latest Barrett value survey, so a drop in our entropy saw from 21% to 15%. Could you provide detailed analysis of the elements that influence this decrease? And we want to understand while specific factors contribute, what specific factors contribute to the decline in the department's scope. Then lastly, Chair, I think Member Jacobs touched on the issue of underspending. So I will not really go into that because I see on table 7 or page 7 table at the bottom, there was a program expenditure underspending the budget. So I wanted to know the details of the facilities that we were affected by the underspending. And also you mentioned also on page 7, the sale of capital assets. What are the capital assets that were sold? Yeah, and I'm not sure the question of Tygerberg Hospital on page 9, the project there, what are the current updates regarding that project? I just need an update on what is happening there. And are there any service providers that have been brought on board? And then my personal experience with Tygerberg, I have the privilege to visit Tygerberg more than twice, and one thing that I observe is that we are sitting with a problem there when it comes to cleaners. I went to the cancer section. My uncle was a patient there, and he was so terrified with what is happening there. The blood, the stuff, it's stinking. There was a certain part, but I called the sister and told her it's not right. So I really want to understand what, in terms of that project, how far are you? Thank you, Chair.
Thank you, members. Before we give over to the responses, for the record, we've been joined by a gentleman. Sir, would you please identify yourself for the record?
Good morning, everybody. My name is Leslie Sylvester, and I'm from the Klipfontein substructure, and I'm on the cluster of Heideveld. Thank you.
Thank you very much, Mr. Sylvester, and welcome. I believe we've also been joined by another member online. Member, would you please introduce yourself? I think it's Member Lekker. Member Lekker, are you online? Or we'll come back to that. I'll now allow for the responses to the follow-up questions.
Thanks, Chair. I'll respond to Honourable Barnes's question around the plan, and how we navigate the fiscal difficulties. While, budget constraints have been a consistent issue over many years, this period was different in that there was a fiscal emergency as a country, which is not the normal budget constraints. It was a fiscal emergency that resulted in billions of rands in austerity being removed from the provincial budget. It also collided with an unfunded wage agreement, and it also collided with significantly higher medical inflation in a budget envelope that didn't even keep pace with ordinary inflation. So it was the coming together of many strands of different things, plus the added pressure with the growing population and so on. So, we do take the point that there have been budget constraints in the past, but in this particular year, it was much more severe and acute than in other years. But that being said, we of course have a plan, and we're tackling it on two fronts. The first is on reducing expenditure, and the other is increasing the fiscal envelope as much as we can. So on reducing expenditure, we're really trying as hard as we can to maximize efficiencies through these cost containment measures, which the HOD has already spoken to in terms of the human resource measures. We're looking at reducing any waste in the system. We're looking, is there anywhere that we could be more efficient? Is there any kind of wastage? How do we stop that? How do we use technology? So, for example, in my opening remarks, I mentioned Georgie, the double robotic device you'll see on the cover of the annual report. Georgie helps specialists to connect with doctors in rural and district hospitals, which means that patient no longer has to travel 1,000 kilometers to Cape Town and back to get additional specialist support. It also means that specialists can help regional hospitals with, more patients can receive specialized care in this way. So that's one instance of how technology can help. We're also looking at efficient management of our inventories and our consumables, being very strict about that. We're also strengthening contract management, which the HOD also spoke about, and how can we realize value for money through contract management. So that's reducing expenditure on the one side and then increasing the fiscal envelope on the other. We're looking at revenue enhancement. So how can we strengthen our billing and collection efforts, in particular for medical aid patients that make use of the public service? We're looking at, for example, how do we recover the debt owed to us by the Road Accident Fund and the Department of Justice, which are significant amounts. We're looking at accessing alternative finance, in particular for our capital build programs, through BFI applications and infrastructure, for example. We're maximizing additional donor funding and funding opportunities. And then, of course, our partnerships. Those are critical in us being able to increase access and care within the constrained fiscal envelope. So, for example, last month we held an InReach project in the Central Karoo, which was led by doctors at the Beaufort West Hospital, where almost 100 cataract surgeries and 250 patients received dental care in 1 week. We were able to pretty much clear the cataract backlog in that week. And that was thanks to a partnership between the department, NGOs like Africa 2020 and the Al Imdad Foundation, as well as the universities that partnered, UWC on the dental side and Stellenbosch University on the cataract surgery side. So we are doing everything possible to make sure that we navigate this and make sure that the department remains stable within the resource constraints that we do face. Thank you.
HOD.
Thank you, Chairperson. Just to go to Member Jacobs's question of on page 7. And I really also just want to stress this point. What you're seeing on page 7 is a total of 200 million under expenditure on the final book closure. So what that means is when we close the books of the allocated budget, the final appropriation that we had, which was 29.7 billion, 200 million was not spent of that money allocated in that specific time. If you go to the last column, and I just want to put that in context because when Mr. Carrick told me this one statistic, it put it into context. Glenn, just tell us how much on average we spend per day for the whole year.
Sorry, I'd have to.
This equates to half a day's expenditure.
Yeah,
about
if that. I mean, and the risk of that is if we don't put in controls, then we can easily land in unauthorized expenditure. But Dr. Chris, can I just correct something here? The number they're looking at is the 22-23 year. And yes, it's still relevant. The saving for this year is 92 million, which we can explain. And I mean, I don't want to go into too much detail, but there are rules in place that National Treasury have put in place to ensure sound financial governance. And the unfortunate or unintentional outcome of that is that we'll always have a saving of some sort. And there's a risk to that. So that 92 million equated to 0.3% of our budget. We can push that saving to about 0.2%, 50 million or 30 million, just to make sure we fall within the rules, because we cannot overspend in a certain program. If we do that, we have unauthorized expenditure. So then you can actually be in the strange situation where you could have a saving, but you would have to pay back some money next year from our new allocation. So it is a force. It's forced upon us. And what is that magic number? So as we say, we normally target to save around 50 million. It was 90 million, but as what Dr. Klitter was trying to explain to you, there is that can equate to half a day's saving in our department. So it is a really risky balancing exercise coming into those last few weeks of the year end.
Yeah. So thank you, Mr. Carrick. So I just want to clarify for Member Jacobs the question. He went to 207 million saving. That's the previous financial year, not the one that we're talking about. In the middle of the page, it's 92 million. And what Mr. Carrick is explaining, that 92 million equates to a half a day's expenditure of our department. And what we're doing is because we need to get on the left side of our balance sheet. The moment you go over with 1 million, it's unauthorized expenditure. Then you're into a whole sea of trying to explain why you spend money that you didn't have. So the rules actually mitigate for you to be within budget. The rules works that there must always be some kind of saving. So I just want to put that into context. It's half a day's worth of expenditure, and that's the context. So it doesn't detract from the fact that all of a sudden we've underspended. Therefore, that is really a technical amount that sits on the books. So
HOD, my apologies, just hold it for a minute. I think this might have triggered a hot hand, Member Walters. I saw your hand going up.
Yeah, Chair, I think we look. I basically what happened here is you have two, we'll call it black swan events, but the one was obviously the inflation around the medical side of things. That's more of a macroeconomic thing. But how can I put it politely? If somebody is stupid enough to make wage agreements without consulting provinces, and that messes up the budgets of the provinces, then there's a knock-on effect to service delivery. If you're stupid enough to not manage your finances, that it turns into a deficit in a budget, it's going to have a knock-on effect for the provinces. So I think the only two from my side, the only two questions that I have is, what is the provincial government making sure they're doing from its side? There's obviously a process that we all as parties engage in to try to fix it at a national level. That's a political process that we're all very hopeful about. But what is the Western Cape government doing as an institution to prevent fiscal emergencies halfway through a budget process that completely disrupts your budget? What's the provincial government doing there? And secondly, what are we doing about the future impact of budget or decisions taken elsewhere that has an impact on the Western Cape government to prevent that from happening? And does that include legal action? I would like to put that to the Minister and the Head of Department.
That is noted. HOD, over to you.
So thank you. I was just putting Member Jacobs's question into context. We're talking about 92 million on page 7. And as we explained, it's a technicality. There's no real saving. It's a technicality for closing the books. I think the question that Member Walters asked as a follow-up on that question is, it is quite important that what we're saying to you, it's unsustainable and it's untenable to have unpredictable financial crises visited on a department mid-year. And we would not want that ever to be repeated. So we can tell you what we have done in response to that. So we have had engagements. Now we have engagements in the province, but we are also part of a national sector, which is the health sector for the whole country. We are working with Provincial Treasury on both of that. So what do you do internally in the department to mitigate that? Internally in the province to mitigate. But what are we also doing with Provincial Treasury through the National Department of Health and National Treasury to prevent that from happening? And it has to be on both sides, because a lot of the money we get for health, the same would go for education, actually comes from the national fiscus as part of the provincial equitable share. So there's quite a few things. And when we do report to you on this in a year's time, you would have seen what we have done in year, in 24, 25, because now we have line of sight. We have not done, in this year, we have full 12-month sight, and you could see, if we explain to you next year, how we've actually mitigated and brought all of those things together. It's different. We're going now into 25, 26, and we want a maintenance of what we've done now, but incrementally build back the investment that's required in public health services, like Member Barnes is saying, because we need to say the needs are not going away. And there needs to be a provincial and national commitment to now build back responsibly from 24, 25 into 25, 26 into 26, 27 in an incremental manner. And part of it is, the problem is, Member Walters, what happened, and we saw it last year. It was black swan, but we saw it coming. Unfortunately, we were the one health department that saw it coming. And we said, you cannot have, because what has happened is a budget process from a national perspective that was almost forced onto the province, became from a 3-year process to a 1-year process, and last year it was a 6-month process. You cannot have a budget thinking that will be, okay, we will fix things and we delay it and we fix it in the adjustment estimate. Then the financial crisis came in. So you can't budget for the next 6 months. And that's why we're saying, actually, you need to now go with a 5-year plan. Actually, you need to budget for 5 years instead of even the 3 years that was eroded back to 1 year. And last year, what happened, that was a 6-month budget, and that was untenable. But
HOD, just a minute. Just a minute, Minister. Members, I can see that we are warming up. And please, in you getting warmed up. Do not put me in a position where I allow a dialogue. We'll have our rounds of questions, and even if the answers are triggering a follow-up, I'll allow for a follow-up. So Member Walters, a second shot, and you'll have to wait for another round if you get heated.
Chair?
Sorry.
Chair, I actually only want to make the remark that I think we should come back to this under resolutions, this particular situation. That was actually not a dialogue point.
All right. Okay, Minister, yes, you may.
Thank you. Then just to complete the response to Honourable Walter's question, as a provincial government, we launched an intergovernmental dispute based on that exact point. And part of the mediation in the resolution that we were seeking was exactly that, was to prevent us ever being in the situation again, and to ensure that the regulations were in fact followed, that there was proper consultation for affected parties, and also that any agreement would necessarily have to be funded. And so we were looking for those principles to be met so that going forward, we don't find ourselves in a similar situation. So we've looked at it from every angle to make sure that we have that kind of budget stability into the future.
Member Van Vogel, are you in agreement with me? I saw you mid-air.
It becomes
Yes.
yeah,
Okay.
and there's still questions that needs to be answered. Thanks, Chair.
All right. Okay, members, I'll come back on follow-ups. HOD, you may continue.
Thank you, Chairperson. So that was one of the questions. So just to go to Member Barnes's other questions, she referred specifically to page 9, and she talks about the discontinued services. So I just want to put this into context. That goes from page 9 over to page 10 for rural health services, renal dialysis, orthopedic services, pediatric dental surgery. Metro health services, no services have been discontinued, but the filling of posts has had an impact, right? If you go to, like for instance, they say prosthodontic and dental laboratory services had to be downscaled. And substance abuse treatment beds at Stikland was reduced. If you go to emergency and clinical services, the Salt River forensic pathology laboratory closed earlier than anticipated due to the rapid infrastructure deterioration. That was not actually a service. It didn't have a service impact because we were moving a delayed move into the forensic pathologist unit that's just under Grootskade, the new observatory. So that was not a discontinuation of a service. It was just that we were trying to keep it going at 2 different places at the same time. And because Salt River was really getting bad, we had to move into a relatively unfinished observatory, but that is not a discontinuation, it's a relocation. So it technically says a discontinuation at Salt River, but that same service started at observatory. So I just want to make that clear to Member Barnes. And then obviously you can see the others.
So it's a matter of English.
It's a matter of English, yeah. But for the reporting purpose, we have to say we closed Salt River. But actually, it wasn't a service discontinuation because we then moved it to Grootskade a little bit earlier than we would have wanted to in terms of that. So if I then can go and just to add to what Minister has answered around Member Barnes's question. So if you ask what is the plans to meet the need, the plans to meet the need is not only dependent on budget. So Minister answered the question that our plans is to say we want to work with partners, we want to raise resources from other sources. So we're not solely dependent only on the fiscus. That's important. But one of the biggest things that we plan to do is actually plan to work with other departments so that the things that cause the health problem in the first place is better mitigated. That's probably our biggest plan. Our biggest plan is to work with safety so that there is less violence. Our bigger plan is to work with education and DSD so that more children stay in school and get educated and less youth problems is visited upon us. So we need to be very clear that that is very clear. It tends to be that we sit in this forum and people think, you know, we say because of the budget, we can't do the direct service delivery. There's a whole process of what our plan is. And to be able to do that, we have to think out of the box. We have to work differently. And we do all kinds of things that actually make sure that we meet the need better. And it would be, we will share that with the committee when we come to talk about the 5-year plan and we come to talk about the 1-year plan, because we have exciting prospects of what that potentially could look like for the next 5 years. So I think that does deal with Member Barnes' question. Member Windvogel's questions. Member Windvogel, I would be disappointed if you don't ask about, it's an inside joke between us, if you didn't ask about COVID. So Mrs. Aris and the team, I'm going to ask Mrs. Aris actually to give a feedback of what we have done to recognize our staff. Because I think we've gone over and above compared to what has happened elsewhere, but we do think we've done justice. Mrs. Aris?
Thank you, Chairperson. I think the reality is that we understand culture must change. Our investment in leadership is critical. But we are talking of the entire department. Am I not audible? Okay. Oh, so sorry. So, the COVID question. Oh, my apologies. My apologies. I was going to the parrots. Okay. So in terms of the COVID, and I know there was the issue of setting up a wall provincially, but it was difficult for us to do that because of the families of members that weren't necessarily comfortable that names be put on the board. At the same time, in the department, at facility level, in the facilities and at facilities, there are names put up boards. And for me, importantly, since COVID, we continually acknowledge at every occasion that we have, because it's not just only COVID, as people have passed on over time, that we acknowledge it in specific celebratory functions that we have. But for each facility, they have spaces that they've put up things and names of people. But as a department, we've not, because in the end, it was not just our department, it was the entire province. And it was just too difficult to get approval from members, from family members to continue on that. Thank you.
Member Windvogel, just to say that, so the ultimate decision we took, we thought we would have this big stone as you come into the arches downstairs. But it tended to be difficult because you have to get the permission of the family for the name to be there. And then because it was the whole of Western Cape government, it became very difficult to get every family to agree that every time we're going to walk in there, we're going to be reminded of the pain that we had. What we decided is each hospital then created a quiet space. So there's like a memorial wall. There's a little garden in certain places. It's really beautiful in certain places where people are recognizing the people that passed away in COVID, but also recognize people that passed away outside of COVID. So those are the things that actually came out naturally and organically. Over and above that, we gave extra time off and leave, Mrs. Aris, to our staff. So there was a national commitment eventually to give people time off in terms of working hard during COVID. But over and above that, we also gave staff additional leave as a recognition. So that's the total package of our recognition, and everybody that has passed away during COVID is not forgotten. And that's where we keep the memory alive, and we continue to do that in that way.
My name keeps coming up. People are losing their memories and
your name. Thank you, sir. So if we then go to the clean audit. So remember, Windvogel, it's a very interesting relationship we have with the Auditor General. So the Auditor General has got a set of rules that results in us getting a clean audit. The Auditor General has been engaging us, and you know, I won't speak for the auditor. I think when you spoke with the Auditor General, you got that sense. Because the Auditor General has asked us and is working with us. It's one thing to get clean financial audits. What is the lived experience of the clients that experience your service? And I must say to you, out of the audit process, the most rewarding thing for me was not to hear we're getting a 6th consecutive clean audit, The most rewarding thing is when the Auditor General went to facilities, spoke to people in the queues, looked at the facilities and got their feedback, and they provided that feedback to us. We didn't initiate that. And the Auditor General tells a story of how our clients are getting a better service from the voices of the people that they themselves engage with, completely unsolicited by us. They tell the story of the ideal clinic story of the Western Cape. They tell all those stories, and that's why they are encouraging us that we need to serve as best practice. That's what you heard from the Auditor General. So these are hard-nosed auditors, Member Van Vogel, that's starting to talk about that the experience of clients in the Western Cape Department of Health for them is increasing because they've been going to our facilities over the years. That does not minimize the individual incidents where sadly the system invariably fails an individual patient or fails an individual family or a group of patients in a group of family. And unfortunately, and that is our biggest reality, a healthcare system can only be organized in such a way that it gives maximum access and maximum benefit to everyone it serves. It can never, ever have enough resources to meet the needs of every single person. That is not unique to us in the Western Cape. It's a global phenomenon. If you have ever watched the news and the media and you see what's happening in the NHS, what's happening in England, what's happening in Canada, what's happening in the US, actually, when I was recently in company of those countries, they marvel at what we achieve compared to the dissatisfaction and the inability of those rich countries to provide access to care. So it's not a unique situation to us. We take it seriously, as you say, for every single person. And we always, for us, the inequality and the unfairness of being in a remote rural setting, as opposed to being within an urban setting where you are in walking distance, sometimes driving distance, there are other factors. So you might be closer in Khayelitsha to care than the person on the rural farm in Matsikama, right at Klipperrand and Molsvlei and all of those places. But the issue is our system must always cater for all the needs of everyone. And that's why we go out of our way. And this is the biggest thing that we've tried to maintain. It would have been easier for us to say, let's pull back all the services with that thing that we just described to you now. Can you imagine, save 500 million in 6 months? The easiest thing would have been, let's close things. And many people actually in Treasury ask us, what are you going to close? Because you're going to have to close. We didn't close things. We had to make sure that we stretch what we do, but still maintain access. That was for ease. And for us, that is a very important thing. And therefore, we want to plan. That's why the solar panels started with the clinic in, what was that one, Klaarwater or whatever. It's like the people in Klaarwater couldn't believe that the first one we went to was Klaarwater. That's where we put that solar panel up. That is our commitment to say that we will work from the periphery in. And that's why when we have the EMS conversation, people are waiting in the middle of Cape Town for an ambulance for 2 hours. And it's unacceptable. But if you take an ambulance in Molsvlei and you take the one ambulance that's in Vredendal and drives to Cape Town, for the next 12 hours, there's no ambulance for all the people in that area. We weigh those two things up. And that is what we do, Member Van Vogel. It is we bring all of those into consideration. And when there's an individual person failed, we acknowledge. We work with the family. We do what we can. We learn from it. And we humbly say, let's learn how we do it better for the next one. So thank you for continuing to bring that to our attention. You will know from our response, we don't dismiss it. We take every single person's care seriously in our department. In terms of the culture and leadership, where Mrs. Aris went to, just to explain to you, this is something that we are extremely proud of. And again, Chairperson, it's difficult for us to talk about it because it sounds like you bragging, right? So it might sound a little bit difficult for us to say. But this Barrett survey is a Western Cape government. It's a Western Cape government thing. Every 2 years, you ask staff a certain set of questions, and based on your results that you get, there is some measures of your culture in your organization. Now, I can say proudly to you, the last Western Cape government culture. Now, if you think of all the people in the Western Cape government, I think there was something like 9,000 people that responded, in our opinion, from us. But if you look at how many people responded from health compared to other departments, it was, we were responsible for 2/3 of the response of all of the Western Cape government. And we're not 2/3, our staff is not 2/3 of Western Cape government. But this thing that's called a culture score of 70, just to put it in context for you, what the entropy means, entropy is a bad thing. So entropy dropping from 21% to 15% is a very good thing, because the ideal is for entropy, you want it to be under 10%. If it's under 10%, people are so happy and so working well together, there's no problems in your workplace. 21%, you get a little bit worried because people, there's a little bit of the satisfaction, there's still a little bit of clash, people don't feel happy. 15%, people are feeling happy. And if you, for best thing under 15%, people will say, I will continue to come to work because I feel a sense of belonging, even though it might be tough. This is where I want to be. That is what 15% means. But that score of 70%, just to give you a sense, Barrett's is an international company. They do it for Western Cape government. They do it in Nedbank. They do it in many other places. University of Stellenbosch does it. We figured out the other day, the University of Western Cape also does it. So there's a whole range of people that use this as a benchmark. When we say a culture score of 70, we ourselves didn't realize that that's our culture score. The benchmark globally for organizations of our type is 46%. So we twice the global benchmark for culture. And that's a little bit of what you experienced, Chairperson, when you spoke to the Auditor General. And we don't say those things lightly, Member Van Vogel, but because you've raised it, you've allowed us to explain that this culture in this organization is actually quite exceptional. And if you ask members working in our department, there's a sense of pride, a sense of belonging, a sense of loyalty to not individuals, but to what the department stands for. So thank you for raising that question. In terms of your underspending question and capital, I think we've explained it in our response to the underspending. But let's go to the Tygerberg PPP. Tygerberg PPP is going to be probably it is the biggest infrastructure undertakings that we've done in our department. It's gone through steps. It's because of PPP, we're doing it with the National Treasury. There's a TA2 approval, it's just a step. And we are proceeding towards all the plans. Now, to do that is we've gone and checked an interest of private parties in wanting to invest into this. There's a big interest. And we shared yesterday with the infrastructure plans for the province, potentially what the development could look like at the Tygerberg, let's call it the Tygerberg precinct. And there's very good plans. The timeframes for this, we're talking towards 2032. So remember, Van Vogel, we are in 2020, we're about to get in 2025. 2032 is 6 years away, but there will be a brand new state-of-the-art hospital with the development of that entire precinct as a health and wellness park with investment from people in the Bellville regional area. It is a very, very exciting prospect. To bring it more proximal to your concern, which is the care in Tygerberg Hospital. Tygerberg Hospital, I've always said to you, is 3,000 beds. It's the single biggest, sorry, not 3,000 beds, 1,800 beds, 3,000 staff members. It is the single biggest facility that we have in the province. It has got significant challenges. The challenges is not only the old infrastructure, but the old infrastructure is completely inappropriate for what we're trying to render in that place. If anybody walk, we took the minister through there, we could see orientation. So we walk and you see, oh, these passages are about to fall apart. And then you enter a brand new refurbished area and you can't believe that you're in the same building. So you have these pockets inside Tygerberg Hospital that over the years we've invested some, but the entire building is inappropriate and it's not fit for purpose. You all know where it was built. It was built with the West Wing and the East Wing. It was built completely differently to the way we actually want to render modern healthcare services. That's why it requires a PPP to replace that building. And 6 years, 7 years from now is a very good horizon to say that forever we'll confine that building to the past. And in there lies the issue of the challenges that you then have to be able to keep a place like that going from a maintenance perspective. Because now the one thing you're saying, we're going to replace it. So you can't invest too much in maintenance and upgrade it because now you have to get the balance right. The other side is to continue to render the services in pockets and disconnected pockets from one another. So then the thing that I know about the smell and all of that is the drainage, and then it's the piping, and it's, you know, so it just becomes, it's another thing. Another pipe is blocked here and another one, which is an old drainage system. So it's a never-ending thing, Member Windvogel, but we continue to work with it. Besides all of that, it is also then the challenge, if we be very honest with you, to keep that entire organization going. When you have something like this, the pressure that was on Tygerberg, and you think that it was in that building, it's the biggest one, and it is more ill patients coming into that setting. This austerity has then a disproportionate impact on a place like Tygerberg compared to other places. Other places can absorb it a little bit better. So our challenges in terms of cleaning, Member Windvogel, in terms of maintaining quality, because in pockets there are excellent care in Tygerberg, right? But in other pockets we struggle. And we are honest about it, we are open about it, and we're very clear about what it is that the unique challenges of Tygerberg poses to us. Thank you, Chairperson.
Member Barnes, thank you for the reinforcement. We need it. Follow-up, Member Windvogel.
Yeah, Chair. That's one of the reasons why the HOD is my favorites. There is honesty and accepting when there's some mistakes. And that's how we learn to rectify those mistakes. And also allow me to also thank the Dr. Karim. I just check an email and it's positive. So I hope we can assist this child. Thank you for that. Then, Chair, my last two questions for now. On page 11 and 12. 11 is the second bullet point under Grooteskier Hospital. You mentioned there on the point of reference, you want to establish an end of life care service. You want to expand that. What are the reasons behind these expansions? Has there been an increase in the number of death, or is it just an anticipation of more death that are expected to be recorded? Then lastly, Chair, on page 12, second sentence under supply, yes. You mentioned the HOD that through you, Chair, unsuccessful bidders are challenging awards more frequently. Could the department provide a detailed type of list? Perhaps it can be part of our resolutions of all awards that have been challenged during the review period, including the reasons by the bid challenge, cited by the bid challenge. Additionally, we have been informed that a company named LBC Multiserve has been awarded a multi-million rand tender by the department, despite not being registered for VAT and or PAYE. Can the department explain how this occurred? And if so, what due diligence process are followed when awarded tenders? Furthermore, could you provide us with all the tender documents, can also be part of our resolutions, because I know they don't have it with them now here. Then, Chair, lastly, on the organizational structure. When we look at the organizational structure in the book, where especially when it comes to employment equity targets, particularly regarding race and gender, is addressing these targets a priority for the department, and are they taken into account when filling vacant positions? And additionally, what are the reasons for the current vacant? I think I don't need to ask the question, because I think the HOD have explained that previously. So I will park there. Thanks, Chair.
While the officials are gearing up, Member Van Vogel, from my side as a chairperson, I must say that we also appreciate your experience in this committee. So we're also learning as you interrogating the reports. Thank you. Minister.
Thank you, Chair. I'm going to take the question on the palliative care, which is being expanded at Grooteskied, but there's a work ongoing in the current financial year in expanding palliative care across the platform. So palliative care is not only for people who are dying. It's an opportunity to enhance someone's quality of life if they have a life-limiting or life-threatening disease or condition. And so extending the service is essentially about providing dignity. It's helping those patients and their families that are obviously very, it can be a very difficult experience, not only for the patient, but for the families. It's to provide that interdisciplinary care for both the patient and their families in what can be sometimes very overwhelming circumstances. And so these teams can provide support, guidance, help to manage pain symptoms, and so on. And sometimes that journey can be very long. And so it's how do we make sure that our patients receive compassionate care for those needs? And I think it's a very important project of the department to strengthen those palliative care needs. So this is a very good development, and we're very happy to talk more about it in a subsequent briefing if there's interest on that.
HOD.
Thank you very much. Just to also indicate to in addition to what the minister said, so just to clarify for Member Van Vogel, mortality rates in this province is going down, not up. Life expectancy is getting better. So we are facing the reality of more people living and living for longer. So just to put that as a backdrop. So something like palliative care is not done against the backdrop of more deaths and more people dying. What we did learn, though, and what is important to understand, one of the most difficult things in healthcare, and it's public and private healthcare, is when somebody has a life-shortening, life-limiting condition. It's difficult for families, and more importantly, it's difficult for healthcare providers to have a conversation with families and with patients about what constitute a dignified end to life and to plan it in advance. And you can imagine when somebody's got an illness in a family and it's an elderly person or somebody, it normally represents, or even a child, it represents a whole lot of complex family dynamics around what happens there. And many people then come into hospital, and unfortunately what happens is many people keep on coming back with ambulances 3 times, 4 times, 5 times in the space of 3 months, where it is undignified what happens to them. So the point is, again, from experiences in other settings, it is much more dignified to not call an ambulance at 3 o'clock in the morning on a weekend when there's lots of drugs and gangs around, for an elderly person to go into that emergency center, which then becomes undignified. It becomes the siblings that's here wanting an answer, the siblings that's overseas or not here wanting an answer. It is a stressful situation. which can be much better. And it's the worst place is in the EC on a Saturday morning to say to the person, there's very little to be able to be done. What we need to do is to make you comfortable to do that. Now, this is a proactive program, and Dr. Arends at the back doesn't only do this because she's done a PhD on this, she does it with a passion. She loves this, she's seen it, she do it with people, and she brings her heart and her compassion into this place. So as Minister Wenger says, if there is a further briefing to be done for the committee, we will do that with pleasure, because it is really one of those things that we actually need the committee to help us with the awareness and the communication of why this is so important. Every person that's older or every person that's young but has a life-limiting condition deserves a dignified end of life. And we must make it as comfortable for the people. And we have the resources to be able to do that. In terms of the unsuccessful bidders, I just want to clarify the name of the company that you spoke about. You mentioned something called multi-serve or something.
Didn't you refer to LBC something? LBC, does that ring a bell, Member Van Vogel? LBC. Yeah. I've tracked your source.
So just to indicate to you, the reason why more unsuccessful bidders challenge is because we are in a financially constrained environment. A lot of companies depends on work. So people become more desperate and challenge more. Ms. Isaacs is here with us. Ms. Isaacs will just give you a very high level understanding of how we deal with unsuccessful bidders. But as you rightfully say, Member Van Vogel, we will provide you which are all the challenges, for what reasons. We can give you all that detail. The specific company you're talking about, if Ms. Isaacs has knowledge of it, but we will then respond to that specific company. But as you rightfully says, this is something that requires detail that we can't provide in this committee. Ms. Isaacs?
Okay, thank you very much for that question. It is so, like our HOD has said, we experience a lot of queries from bidders daily with regards to the award of bids. Unfortunately, when we award tenders, bids, quotations, it's not enough to sustain any bidder or the economy really, because it's just a few that we have to award. So with the unsuccessful bidders, there are basically more than one process to follow to approach the department to find out what went wrong in a bid. And what we do is we investigate each and every case, and then we provide the feedback. With regards to the company LBC, this came to our attention a week ago. It pertains to a stationary bid. And that matter is under investigation because apparently, as per the applicant, the challenger, has put to the table that the successful bidders do not have necessary documentation. So that is being investigated as we speak. And we received the documentation 2 days ago. So we will then look into that matter and then take it through the necessary channels and then provide a response. The list of bidders who have challenged the department's decisions legally, that we can also provide to you as soon as possible outside of this meeting.
Thank you very much. But just to add to what Ms. Isaac is saying, this adds another layer of complexity in rendering the services by having then to almost legally defend every single decision that you take. So it's just another additional complexity that's added into our environment, but the supply chain team is really working full out to look at all of those. And yeah, so I think, Member Van Vogel, we've just the last one, is if you look at this, the senior management reflection and what you see as the organogram. In terms of employment equity, we are at pains to say that we are recruiting for a transformation of the senior management team in this. Now, because Member Windvogel has got long history and experience with this committee, she would have noticed that there's a transformation over the years. So our intent always is when we look at people coming into senior management positions, to look at fairness and representativity in terms of how we do the recruitment and selection. So we can give Member Windvogel and the committee our full assurance that this team is committed to diversity, and we're committed towards making sure that we have representativity in our senior management team. Thank you, Chairperson.
Member Jacobs.
Thank you, Chairperson. Just a question on what we're talking about here, with regards to the unsuccessful bidders, and we do understand what's happening there. But my question to you is, the successful bidders, how do we make sure that these are not fraudulent companies or companies that has been involved in corrupted activities? I'm just making an example. So can we go to the Somerset Hospital? There's a company there called TCC. Now, they have been red flagged by the City of Cape Town for fraudulent activities, right? So they get no businesses within the City of Cape Town. How do we, as this department, how is it possible that those companies get us tenders? Because we're talking about unsuccessful bidders. So is there maybe something happening there within supply chain management? Because if we look at what's happening within the City of Cape Town, there's a lot of fraud and corruption happening within supply chain management. Do we have the same situation here by us?
HOD?
I can say to Member Jacobs that you have to only go as recent as the PPE adjudication and SIU, Auditor General, I don't know how many other investigators has looked at all our processes. Recently, the Auditor General went into a whole thing about infrastructure. Not a single willful case of fraudulency has been uncovered in our supply chain, the process. The issue that the members are raising is an interesting issue because one of the things we do is we work and we meet regularly with the Provincial Forensic Services. So we have a lot of whistleblowers that reported Provincial Forensic Services, and many of it is actually also us as the department referred to the Provincial Forensic Services through our internal controls. If we pick up something untoward, we are one of the big referrers to the Provincial Forensic Service. And we have a zero tolerance for any corrupt activity. So when we come this afternoon at Scopa, you will see that there are some people that has been dismissed. We take that very seriously, and we have a very, very clear record of dismissing people that's found to have done corrupt activity. One of the things that Provincial Forensic Services did ask us, though, is we have this phenomenon that certain companies have done work with us, and we found them to be unethical. So the issue of blacklisting a company and how that is transversally applicable to other companies is something that is required, and I'm glad he's asking it because we have escalated that to Provincial Treasury, and then to work not only within this department, but to work across departments. That the kind of flagging system that he's referring to for the City of Cape Town should be equally applicable across all entities in terms of that. So we have registered now, I think, 2 companies. The way that you've described it, Member Jacobs, we are registering to other people. Don't do business with these 2 companies because we have had bad experiences and they are blocked from all business with our department. It's that joining up of that rigorous vetting system across departments, which is an important thing to follow. And we believe that that's Provincial Treasury's role to facilitate across departments. Thank you.
Thank you, HOD. Members, can we go into part B? Then that will take us to tea time. Member Van Vogel.
Thank you, Chair. I'm just thinking now, Chair, the HOD mentioned about the service pressure at our clinics and hospitals, especially the emergency side. Perhaps we need to submit a recommendation to the President to institute the weekend lockdowns in the future. That will help the weekends, the influx, because I think that's the huge problem. It's weekends. It becomes, it's not nice to be in the emergency side of the hospital. But nevertheless, Chair, mine is on page, it's just a joke, but it is serious. I don't want to be killed after the meeting, when I get to Swellendam or wherever, because people hate lockdown. But I think on part B, Chair, on page 25.
Sorry, member. Before we go into part B, I did say that we can go into part B, but then I saw some hands that want to. The last one, it was Member Stevens and then Member Barnes. Member Stevens. No, we're still in part A. Am I correct?
Yes,
okay,
yes,
still in part A. We're not in part B yet. Member Stevens. Or were you raising your hand for part B?
Also, she also want to be in part.
Okay, close it off for us, Member Barnes, part A.
Thank you, Chair. It's just a follow-up I've been wanting to make following the questions. The one of LBC multi-self of Member Van Vogel, where I think the department responded on the challenge that they picked up last week on irregularities, whereas the bid was done earlier this year. Could it be that there have been problems within supply chain? Because if you look at the time frame from this year early and you only pick up last week a matter, could there be challenges on supply chain management if maybe the department can take us into confidence with that? Thank you, Chair.
HOD?
Member Barnes, I can speak to you. Mr. K is on the line, but our oversight and with Ms. Isaacs over the supply chain processes is quite a rigorous one. And obviously, we are going to have processes where we have challenges, processes where allegations are made, processes where information comes to light, and then we do what we need to do to investigate all of those. I don't know, Mr. K, if you're online, if you just want to make a comment on that? Oh, it's just been called to step out. Okay. So I can give the assurance to Member Barnes that our oversight is of such a nature. And we also work with Provincial Treasury Supply Chain, that if there is any challenges in our own space, we look at another pair of eyes to give us that. So we can give you the assurance that we take that extremely seriously. Thank you.
Thank you, HOD. We're now going to part B, and part B will be kicked off by Member Stevens. That is from pages 24 to 116, and please refer to the pages if questions are related to that. Thank you.
Thank you, Chair. I've got one or two questions from page 26, 27, and 28. We did a few visits the past 4 weeks. And I know that the HOD said, explained about service deliveries and the shortage of staff and all that. And that they did also speak about, they did also visits and where they only got excellent comments or good comments. But for me, this is not what happened where we visited, and we visited the whole of the Western Cape in the past 3 to 4 weeks on oversight visits. And on page 6, service delivery challenges. Patients experience long waiting times before they receive treatment, closure of hospital wards and beds, lack of critical resources such as staff, etc. Above mentioned are some of the issues that are mentioned as some challenges, yet these challenges are only prevalent in the black and coloured healthcare centres, day hospitals, where our patients are also treated with a lot of disrespect. At Cryven Day Hospital, this is just an example, but I actually thought it's only there, but with the visits, to me, it happened all over in the Western Cape. Where Patients are queuing as early as 3 o'clock in the mornings, come rain or sunshine, and are not allowed on the day hospital grounds until the official opening hours. How do you intend to eradicate these crucial challenges, especially in the disadvantaged communities, and treat patients with dignity and respect? On page 27.
So remember, before you go to page 27,
yes,
for my own understanding as well, could you probably be specific on where, maybe if you can remember name of a hospital or a clinic, so
Yes,
when the officials follow up, then they know
yes,
exactly
there
what
was for instance, the Kryford Day Hospital. I've got first-hand experience of that hospital. We went to George. We went to Caledon yesterday, where the community had to give input on the older person's bill, but instead there was a lot of complaining regarding the clinics and the day hospitals, where old people yesterday complained where they had to wait sometimes 2 days at a day hospital for help. At the hospitals, they travel 2 or 3 days to get to a hospital with appointments where they get told there's no medication. And it was all over. We were on the West Coast. We were in Caledon. We were in George, all over the same complaints. No help. We were at some hospitals. I know there was one in the hospital that we walked in the Sunday that was I think in Neisner, where there was people sitting for 2 days without help. There was an accident the Saturday. We met the patient at the police station, where the patient walked out. Well, husband went to go fetch her, took her to the police station, where she was sitting since the Saturday night with the accident till the Sunday afternoon without anybody seeing that patient. And it happened all over where we went. People was complaining about the same thing, no service. And to me, that was really bad, and especially to our old people. So
we have an idea, member. You can continue.
And then on page 27, a critical question for me is on page 27 regarding the Alexandra and the Lentegeur psychiatric hospitals, which have a large, stable, long-stay population and are facing increased pressure to accept transfers of individuals. What concrete actions are being taken to address the high bed occupancy rates in psychiatric facilities, and how can we expect improvements in service delivery? How will the Western Cape government ensure that mental health services are equitably distributed across urban and rural areas? And what strategies are in place to reduce waiting times for child and adolescent mental health services? And I move on to page 28. On page 28, it says it is noted that many foreign national patients are referred to the Groote Schuur Hospital, which are leading to increased waiting times for South African patients. This is unacceptable. South Africans should get preference above foreign nationals, and it is South African taxpayers' money that are being used for these services. It raises the question of how many of these foreign nationals are illegally in the country. How is the department going to address this, as it is strain on the health sector, have a negative effect on South African patients? Then one of the steps to address challenges is by revenue generation initiatives are being implemented on supplement government funding. Please elaborate on how revenue are going to be generated and how it will affect the disadvantaged, underprivileged who cannot afford to pay as for even basic healthcare services. Thank you.
Member van Wyk.
Thanks, Chair. I was just wanting to query on where we're dealing with some of the outcomes here. We refer to an actual achievement until Q2 of 23-24. That we just understand the context of that in the evaluation.
What page is that? All right. Okay. Okay. Member Winvogel, I saw your hand earlier. For part B? Part B, yes.
Chairperson, I'm just checking now, Chair, if we are on Part B to page 25, emergency medical service. On our oversight visits, we normally ask the EMS section also to come and present something. And I call them the most hated people in some areas. And it's so unfortunate because those guys really are there to help and assist. But because of the system, failing them, it becomes they becomes the villains in the story. But nevertheless, I just want to understand in wherever we go, emergency service understaffed, there's not enough ambulances and so on. And people are waiting for hours. And then also the safety of staff of the EMS team, it becomes a problem. And I'm happy to hear from the HOD that they are trying to work with other departments. So it will actually be a good thing when it even comes to this issue. So I want to understand, is the current number of staff in vehicles, according to the departments, enough to handle the volume of incidents reported? Because in the annual report there was a nice part where you explain how many and how many was reacted on and so on and so on. So and how much does the under-resourcing of EMS contribute to issues of patients waiting for hours for ambulance that never arrive? So if I can get the understanding about that, then Chairperson, on page 26, a part of point of reference, I think I will
Park there for now.
It's page 27, sorry. Page 27, mental health services. Could the department provide an overview of the challenges faced by psychiatric patient facilities and explain how fiscal pressure have exacerbated these issues? Then on page 28, Chair.
Sorry, member, can you please repeat your last question? Can you please repeat it?
Could the department provide an overview of the challenges faced by the psychiatric facilities?
Page 27.
And explain how fiscal pressure have exacerbated these issues. Then on page 28, could you elaborate on the challenges faced at Groote Schuur, Red Cross, and Tiger Bay Hospital? Specifically, how many positions remain unfilled? And why were the posts of Red Cross not filled? Is it also part of your explanation earlier? And if it was now the explanation, if this is part of that explanation, I want to understand the impact it has on the service delivery in those 3 hospitals. Thank you, Chair.
Member Jacobs, then Member Barnes.
Thank you, Chair. Thank you, Chair. Yeah, I just got one question, Chair. I think it's on page 27, the last paragraph. Staff who have completed the emergency care assistance course are unable to be promoted due to the absence of this rank in the current occupation. I'm confused when I read that. Are we wasting money here? Or can the department just explain that to me, please? Thank you.
Member Barnes.
Thank you, Chair. Just a quick comment, Chair. When I was online, I was in a public space tuning into the meeting, and I was fortunate to be surrounded by the public.
they asked me to convey this message. They say they will follow up. They enjoyed the qualitative questions that were asked. They were real, they were clapping hands. So they said I must convey to the committee that they are listening and they feel attached. It's the real issues, the real questions. So I thought, let me just share it because I was in public space at that time. Everybody ended up joining and tuning in into my meeting. So big up committee to asking the real questions people want to hear. Chair, I'm on page 30 on the part of resignations and appointments of senior management. Chair, when you open up that chapter in the book, it only shows you the senior management part. I would have interest into seeing it filtering down to the lower level as to how many up until the paramedics, how many how do you call them, CNC nurses, how many have resigned, and the reasons thereof also. The reason I'm asking this question is that I've made an observation of seeing lots of EMS workers. Let me be specific. In my previous constituency, Beaufort West, I've seen many of them resigning, and one would want to know as to the reasons thereof. If maybe the department can also take us through to that as to what may be the reason of a series of resignations, especially on a lower level, and also the plan of the department on retainment and also of transferring of skills or second layer leadership. What are the plans in moving forward? And then, Chair, my second question would be on page 36 at the bottom table, patient experience of care satisfaction. According to that chapter, it says that the satisfaction on the measurement of patient satisfaction. What I would want to know is that how do you measure patient satisfaction? I think ordinarily on oversights, what we would always ask is when you find the patients, when you are there on oversight and you would ask them, when you are complaining, how are you complaining? And you are shown that box, that little box at the clinic or at the hospital where you put in your complaints. Now, what I want to know is the department looking at that and how do they say that it is satisfactory? Is it based on the number that is coming in, or how do you measure the satisfaction? Are you measuring the complaint box, those little letters that are coming in? Can you also take us into the process as to saying that this is a satisfied patient or just take us into confidence, because I'm not really clear as to how you get to a conclusion of saying that this is how we measure it and this is the outcome of us saying that we are having happy patients. And then again on page 37, the ideal clinics. I think also being part of the previous administration, we observed that the department consistently underperformed in relation to the ideal clinic status. What changes have contributed in this department to improve this time? And what strategies and practices are put in place to make a difference? And then my last question, Chair, would be on page 40, the third table, under neonatal death in facility rate. What is the number of infants that died during this year under review, and what factors contributed to these deaths? Thank you, Chair.
Thank you, members. I'll now give over to the officials to answer.
Yeah, now thank you for all the questions. So I'm going to go in the sequence of how they were posed. So Member Stevens's question on page 25, 26, 27, there's a bit of overlap with some of the subsequent questions, and I will not repeat the answer. So Member Stevens, I tried to explain at the beginning, the impact is felt everywhere. So when I say the Auditor General goes in, they go unsolicited. They go to facilities in the middle of the day, talk to patients, talk to people about their experience in the facility. They're actually in the facility while people are there. And they talk to them while they are queuing, while they're waiting, while they get treatment. And that for me is the most heartening thing that I've heard, because their experience to us is the people that's sitting in the facility waiting to see the sister and actually sees the sister and comes out. Those people are saying, this is what we experience. And I'm not discounting the people that goes to community gatherings that says, I'm sitting forever, old people sit forever, everyone sit forever, because as the chairperson says, what is the detail of each individual case? Unless we know the detail of each individual case, it becomes a generalization. Generalizations and narratives are powerful things, but we're also dealing with generalization and narratives because it easily becomes, I've heard somebody say so. That is what I've experienced. When you go and say, well, 5 years ago when I went, this is what happened. And we guard against generalizations and narratives that are then perpetuated, because that's where we want the detail and we want to actually engage in an honest, meaningful way with the things. Having said that, the issues about specifically what you experience in the places when people then say they have a bad experience. So what is our response to that? Because the issue goes about dignity of the persons. There is a mismatch. Let me put it to you this way. I've discussed this with Minister to orientate her to say one of the biggest things she's going to hear is she's going to hear all these individual things come to her. And when people get her cell phone number and people get, then she will hear all these cases. The big thing is there's a mismatch in expectation. And we really want to go this year. And maybe Windvogel, you understand that language as well. There's an expectation that in some cases people have a legitimate expectation. Whether we can meet that expectation and whether we can meet it or cannot meet it, whether there's a conversation of why we cannot meet a specific expectation. And we really would like the committee to also help us with that, because it's an honest conversation about expectations and being able to meet expectations. Many instances, if we just understand the expectation, then we can say, but actually, because this is what happens when people formally write a complaint. So the first thing they say is they are very heated under the collar. They write to me and use expletive language. I send somebody writes to them and say, let's understand what happened. Have a conversation. Invariably within 2 days or a day, people say, thank you for having listened to me. I now understand. Thank you for the next time. This is what. So there is no shortcut for dealing with individuals, people's expectation, and then individualizing our responses accordingly. That's why we say to Member Windvogel, we have a general thing, but every person counts, and we will continue to engage. And that's why when we say, please give us the detail, it is about the actual episode, on which day, and who was involved, and what was the circumstances, so that we can actually deal with it in that regard. So when you say at Kraaifontein, when you say at George, when you say at West Coast, when you say at Knysna, give us the individual details and we will follow through on each one of them, because that is what we do in that regard. When it comes to the psychiatric facilities, and there's a question asked by Member Windvogel later as well. Psychiatric facilities are under disproportionate pressure for many reasons. We have had a mental health challenge prior to COVID. And we were trying to respond to that challenge before COVID. One of the things that COVID has exacerbated was mental health. We now have a greater understanding of the drivers of it. One of the biggest drivers is substance abuse. So if you really want to understand how mental health has escalated, is to understand the use of substances and addiction. Because it's almost like the primary big driver of why we have the pressures that we have. So you can see it would be, again, the comment would be, if you really want to address the issue of mental health, you need to go back to the root cause of why people are using the drugs in the first place and the substances. And that's why we are very excited now, and maybe I shouldn't mention it now because it's not part of this reporting in it, but in this reporting period, a pilot that was called Planet Youth was done in Garden Route, in Thembalethu area. It's in Thembalethu area, and that Planet Youth has give us so much promise. Because literally, I can ask the question there for you, what came out of this survey in Thembalethu. Of the kids whose parents, and this is 13 to 14-year-olds that does the survey, in the last 30 days, how many of you were drunk? Now, the kids whose parents doesn't approve of them taking alcohol and really say to them, I don't want you to be drunk. 10% of them said they were drunk in the last 30 days. Of the ones whose parents don't care or actually approves, 47% of them were drunk in the last 30 days. That's even before we've done anything. It just shows you the power of the parent taking an interest and saying, I don't want my child to be drunk. Now I can imagine, and that's what Planet Youth is showing up. It's not the health system's responsibility. It's not the education system. It is the community's responsibility to collectively take responsibility. Now that I'm taking you from the psychiatric beds and all of that back to Planet Youth, and that's the link between the two. That's why for us investing in doing things differently, hopefully there's less substance abuse, so that there's less pressure on psychiatric, so that the people with a psychiatric condition like depression, like schizophrenia, can have access, because at the moment they are crowded out by the substance abuse and the young people that comes into the 72 observation into the hospitals. So you have to see your question about psychiatric questions against that backdrop. So when we say we can add psychiatric beds, we are not doing justice to our response. We have to increase capacity. We have to make sure that we have more capacity, but it's more important that we actually stop the reasons of why the psychiatric problem is there. So hopefully that makes sense to you. And we have a process with the education department, with DCAS, with the municipalities to invest in our interventions to try and stop the abuse of substances in that regard. When it comes to the foreign nationals coming into our service, so we operate from a constitutional imperative that we as a healthcare system cannot deny access to anyone when they are in need of emergency care. So when you present to a health facility and you need emergency care, the Constitution doesn't allow us to say to you, are you South African or not South African? Constitution says to us, we will treat you irrespective of where you come from. And because of that, we hold that very dear, member. I mean, it's our constitutional obligation to not deny anybody access to emergency care. It is when it goes beyond the emergency care that we then start asking legitimate questions, like at Grootske, of if you have to have access to a cardiac transplant, which is rare, and we have a waiting list, then our question is, can we recoup that money for cardiac transplant from your country of origin? And that is the policy that we've got built into our system. So we do it in a way that it is fair to everyone, and we do not deny access to the people that deserve access to care. When it comes to revenue generation, I think the very important point we're trying to make with the revenue generation is that we have a big potential to generate revenue. And that is people that actually, in this province, a lot of people that's on medical aid actually use the public health system. We ran a process recently where we said we're not going to ask, because we might make care free of charge at the point of care. So we don't ask you pay upfront before you access our care. But we reserve the right to bill you afterwards. What we did is we looked at all the people that came to our primary care facility, which is free of charge. And then we went to check, our finance guys went to check. But there's a lot of people that we have evidence that the person's got medical aid and they got free primary care. We started billing them now. And the medical aid is starting to pay us. So for us, it's not about denying people access as point of entry by asking them to pay. It's for us to have systems to be able to go, and from the ones that comes to primary care that has medical aid, that we can recuperate that money out of this. So it's just an example of the kind of things that our teams are doing. With the hospitals, we do the same. And one of the things that we found is medical aids actually prefer to work with us because of how organized our finance team is. And many medical aids has actually written to us and say, do you want to become a preferred provider for our medical aid? So they're writing it into their medical schemes that you in the Western Cape will use the public health because, but that's the place that we want you to get the care from. And we have a billing system set up. Our guys almost interface right with that medical aid, they get their claim, we get the payment into our revenue. So we've done all of that. Where we've not been successful is getting money back from other government entities. So road traffic accident, or road, what's it, RAF?
Road accident fund.
Road accident funds. We've struggled. We've had interministerial, we've raised, but there are money sitting in the road accident fund that is due to us. So it's difficult when we are having difficulty with the budget to know that we've rendered the service, but another entity has received the money and we're not getting our due course of that money.
We'll talk to their friends. They have friends here on the committee.
Okay. And then the second one is the Department of Justice, because we do quite a lot of work in psychiatric facilities, actually, that is under the Criminals Procedure Act. We're actually doing it in the psychiatric facility on behalf of the Department of Justice. And they are also duty bound to reimburse us for the money that we spend on people under the Criminal Procedures Act. So hopefully, Member Stevens, that answers your questions. So, yeah.
If I may, just add on the medical aid point. In the equitable share, in the monies that's given to provinces, there are different components. One of them is the health component. And in the health component, it's the number of people on medical aid is measured. The more people on medical aid in a province, the less funding you get, right? Because the assumption is that medical aid patients don't use public health care. But the reality is different. Medical aid patients do make use of the public service. So on the one side, we're having money removed from the health component of the equitable share based on those medical aid patients, but they are in fact using our services. So what we're saying then is, if that is so, then we should be able to then bill accordingly on the other side to create that balance.
Sorry, HOD members, may I propose that we go on tea and be back at 11 o'clock? You can have your follow-up when we come back, member. Or HOD, do you want to? All right, okay. Permission granted.
Yeah. So thank you, sir. Member van Wyk asked the question about performance, and it's in somewhere in this, you will see in the whole of section B, it says performance up until Q2. And then what you need to read is later, that same table is repeated. And it then says annual performance. What that means, for each one where you see up until Q2, that is an indicator that mid-year, like as part of the adjustment estimate, we revised the target. Because when we saw what happened at that time with the financial crunch, we went as part of the adjustment estimate and revised a lot of targets in this. So every time you see up until Q2, it's a revised target. What you need to look for is the table a little bit further on where the revised target then appears. And that's part of the template that we provided. So it looks a bit clumsy, but it's constantly, each table has another table with a revised target. In terms of Member Jacobs, the emergency care practitioner on page 27, this is a positive story. And I really invite the committee to also understand what we're doing with emergency care assistance. Because we have an emergency EMS college that's now a formal higher education institution. And they do phenomenal work. And one of the practitioners that we are qualifying is an emergency care assistant. The OSD is a rigid structure. So the OSD has been previously come forward to say this is an occupation-specific dispensation. Now, because we have new categories, it was not catered for in the OSD. It's a challenge, but the OSD is in its process currently, in the process of being completely revised. So this is a very positive development for us because we're creating a category of staff that would be essential in the EMS questions that Member Van Vogel is asking for. When we talk about staff members for EMS, Member Van Vogel, this emergency care assistant will be a huge addition into that place. But it's not the only place where this is a problem for Member Jacobs. For instance, in forensic pathology, we have a forensic pathology office. They're the backbone of a service of forensic, but they're not recognized in the OSD as well. So there are many places. And because we are a little bit producing these quality products, people that works in our system, the systems that we've designed, which was designed 10 years ago, is not quite keeping up with tracking that. So that's the discrepancy. Member Barnes, the question about SMS and at lower levels, I think that's quite an important question. You can obviously understand SMS, we're talking about 60 people. When we talk other people, we're talking about the balance of the 3,240 people. So it's 33,000. So this goes into reams and reams and reams of information about people. But we are constantly looking at exit of people from our system, why they're exiting, and we are constantly analyzing how we should be responding to it. So your point is extremely well taken. And we are currently looking at nursing and understanding what's happening with the nursing of exiting. And your question about the retention and skills transfer. Retention is the culture and the conditions inviting for the person to stay. Transfer of skill is getting the right skills of people to stay in our organization. And we will have a 3-level, Mrs. Aris and the team is telling us, we need to future-proof our organization by making sure that our skills in any area runs at least 3 levels deep. And I can promise you, if we achieve that, we will be setting up this department for the next 3 decades, I guess, by that rigorous investment. So thank you for the question. And we do have the information, we do look at it. In terms of the patient satisfaction, Leslie is here, so if there needs to be a follow-up, we can come back to it. But this is a set national indicator, and it is on the basis of a survey. So it is a survey of people in our services that get surveyed to say, how did you find the service from 1 to 5? What do you say? Da, da, da. And we do the survey in accordance with the guidelines that provided. So again, to member questions, 80% of the people that we surveyed are satisfied with the service. And that is up from 72% of the year before. And that's the people that's being asked that actually renders the service. When you go to the ideal clinic, you can see the performance has gone up to 87. We are increasing our performance. The indicators that the things that we've done as the investment is an investment to take the ideal clinic's assessment seriously. And that's linked to the Office of Standard Compliance Assessments. And our investments has been making sure that the right equipment is there, making sure the drugs are there, making sure that the right staffing is there. So it's been systematic investments, and therefore the ideal clinic status is improving in terms of that. And the neonatal rate, death rate, is a very important marker of a successful birthing service. We call it perinatal service. And our neonatal rate is the lowest in the country by far. Because we have a good obstetric service. And neonatal is first 30 days of life. So the baby is in 30 days. So we call it early neonatal is the first 7 days. Late neonatal is from 8 days to 30 days. So we have a low figure for that. And we have a system which is called a PIP system, PPIP system, which looks at every single case and say when there is a death, is it a patient factor? Is it a health system factor? Is it a health worker factor, patient factor, health worker factor, and a system factor. And on all of that, we then improve our systems accordingly. So that's quite a detailed system underlying our analysis of neonatal mortality. Member Windvogel, just to come back to your questions. The EMS villains, I just wrote it like that. Dr. Arendse is in charge of emergency services, so it falls under her area of responsibility. And there is a twofold thing. If we say how many EMS practitioners we need, how many ambulances we need per population, we do not have enough in the whole province. I explained it earlier. And obviously, we would want to make it more equitable with what we have. So the ideal is to be able to increase our footprint. But we are constrained by the reality of the resources because we're balancing that up against nursing, doctors, this, Grootskede, Tygerberg, all of that. So it's part of the balancing act. An important thing, though, is that EMS should be protected by everyone and not be unnecessarily used. Because if that's the issue, and this is the problem with all the complaints that comes out, but people do not understand when the complaint comes, is the EMS was not available for the emergency because somebody else was inappropriately using the EMS at that time. And also, when the most complaints come out is when most people are irresponsible and drink your weekends and they stab one another. And therefore, when the EMS is needed for the person with a heart attack, we're driving around the guys that's been stabbing one another and trying to get that. So there's a bigger thing about safeguarding the EMS that we do have so that we can use them more effectively. So that is a big consideration, and we're looking at that. I think I've answered the psychiatric hospital question. And then just the impact on Grootske Tygerberg and Red Cross. It is part of my previous answer because no health facility was spared. And within each of the services, I'm glad to say you will see from that table, no service has been discontinued at those hospitals. But because of the constraint of staff, the services have been constrained. That means if you waited for 2 months for something, now you're waiting for 4 months. If you waited for 6 months, now you're waiting for 9 months. That is what the impact has been. And that is a phenomenon across all of it. Chairperson, I hope that was quick enough. Thank you.
Thank you, HOD. Folks, we're having a tea break. We need to be back at 11:05, including smoking. Member Walters, that includes smoking. And refreshments, tea and coffee in the members' lounge. Thank you.
Yeah.
Members, Minister and the professionals, it's exactly 11:05. We're back from a tea break, so we're going to commence. But before I do so, I've noticed that we've been joined by a gentleman in the meanwhile. Sir, would you please introduce yourself for the record?
I must greet everyone in this beautiful chamber. I'm Mr. Linda Peter from Kraaifontein. I'm community activist under the health.
Welcome, Mr. Peter, and thank you for attending. Members, we are still at part B, which is pages 24 to 116. We may commence from there. And before we left, some questions were answered, and I don't know whether there are any follow-ups. Member Van Voorhel?
Chair, no, mine was on question raised by Member Stevens, and the HOD touched on the issue of the foreign nationals. I just wanted to check with the department when our government provide assistance for foreign nationals. Do we bill their governments for the costs occurred? That's just a follow-up on that question.
Okay, I don't see any other hands. HOD?
As I indicated to Member Christians, the emergency care we offer to everyone irrespective of origin or where they come from. When it comes to very expensive elective procedures, and I use the example of transplants and all of those, we have a national policy, Member Van Voorhel, where we are, according to the national policy, in a position to try and recoup the money from the government of the country of origin of the person. What does influence it, though, is whether the person is under refugee status or whether they are a permanent resident here. It does changes the conditions, but we have a policy to be able to recoup for elective procedures via a claiming mechanism from the country of origin. We do claim, and Grootskeur is obviously looking at that. And in many instances, we do get the money, but in many instances also we don't get the money, but there is a process that we can follow through for the claims.
Thank you for that. So remember Van Voorhel,
yeah. Then, Chairperson, on page 41, first table, I want to know what is the number of HIV positive children in our province? And then on page 43, table on top, what was the final achievement at the end of the fourth quarter? Was the target achieved? And what makes it difficult to trace these patients? That is 43 table on top, TB pre-XDR lost the follow-up rate. That's the point of reference.
Page 43.
Is a table. For me?
Yes, for me.
Okay. Then, Chair, yeah. On page 44, table at the bottom, in front of first PCR test positive around 6 months rate. Why was the target not achieved? And then on page 45, table on top, the HIV test positive around 8, the point of reference is saying that HIV test positive around 80 months rate. Why was the target also not achieved there? And then on page 46, the second last paragraph, the point of reference, ART child viral load suppress rate, then 12 months. Why is the target not achieved? How do these children get HIV? What is the prevalence of mother to child in the province? And then on page 47, table at the bottom, you mentioned the point of reference are all DS and TB client lost to follow up. Right. Why was the target not achieved also there? Then on page 49, strategies to overcome underperformance. While we note the mentioned strategies to overcome underperformance and really wish they will help address the challenges, but the most important question here is on whether we have enough midwife across all hospitals, which facilities reported infant deaths. And then lastly, Chair, on page 50, second table, child under 5, point of reference, child under 5 years, severe case fatality rate. I just want to check how many children have died in the province as a result of malnutrition in the province since 2019. And do we have breakdowns of these deaths per municipality? Thank you, Chair.
I don't see any other hands at this stage. Yeah, we'll keep it at that, HOD.
I'm going to try and just quickly run through, because each of them have got a technical answer, but I'll try and do my best in terms of dealing with them. So let me start on page 41. Just to explain, when we say odd child viral load suppressed rate at 12 months, we are talking about the person, well, of all the people that, all the children that have ART, that is on ART, how many of them are suppressed at 12 months? Now, this is an example of what Member Van Wyk asked. So you see this table on the top of 41, that the plan target was 67%, but for Q2, it was 41%, right? As part of our adjustment of that target, I have to take you to page, sorry, which one? 49. To 49. So it's the same one that you, sorry, 46. I'll take you to 46, yeah. Then you have to look for child remaining in care, suppressed, viral load suppressed. It's the third one. And you'll see that the target then was reduced to 40%. And the attainment was 37.6%. So we're 2% off target. Just to take that in numbers, you will see, therefore, the indicator, sorry, let me just work that out. The numerator is 52 and the denominator is 150. So when you ask how many children are HIV positive on treatment, it's 130, which says it's D at the bottom here, right? And it says how many were suppressed is 52. That is what we planned. What was actually, now it's very difficult to say this is how many children you're going to have that's going to be HIV positive, that is going to be in treatment. So in the end, we had 133, of which 50 was suppressed. So we achieved the 50, but there were 3 more children on treatment than what we planned. And this is a problem with target setting at the time that you signed it off, which was like in February. It's then adjusted, because what you have in the end is not quite the same, because you can't be in a crystal ball and say we are going to have 50 people on treatment and then it is 50 people on treatment. So that, just to explain that one indicator to you, that's illustrating the point that was made earlier. We adjusted the target and 50 children were suppressed as planned by us. But in the end, there was 133, not 130. And that's what gives you the targets. I hope that answers your question, Member Van Vogel. Okay. So if we then take the next one, which is 43, which is then pre-TB XDR, which is in 43, right? And again, you'll see Q2. So it's the same phenomenon. So now I have to take you to 49. For that same one, it's the last table. So you can see the target has been adjusted here to 24%. Right? So we thought that 32 out of 130, that was what we targeting, that would be lost to follow-up rate. What transpired is that 35 out of 127 was lost. So you can see, again, the same phenomenon. We thought around 32 people we would like to limit it to. It was 35, so it's 3 more. But the total number of people that was in that category was actually 127 in the end and not 130. And that explains the figure that you get. Now, for both of these, just to stop there, the first one, why it's important is the question. So for the first one, all the children that has HIV and is on ART, we want them to be viral load suppressed. One of our big challenges is, and you will hear in HIV and TB, this thing called about 95, 95, 95. And the idea is we want to know 95% of people that have TB, we know them, so we must pick them up. 95% of TB that is known to us is on treatment, and 95% is successfully treated. That's for TB. For HIV is we want 95% of everybody that's HIV positive to be picked up. We want 95% of them to remain in care, to be put on treatment, present treatment, and then they must be virally suppressed, which is that viral suppressed is the third 95. So when we talk about viral suppression, it is we want to pick up people with HIV, we want to make sure they're on treatment, and if the ones is on treatment, we want their viral load to be suppressed. It means that their condition is under control. So that's why the child viral load suppression comes out of that thinking. Whereas the pre-XDR loss to follow-up, right, is we want to pick up the TB case. So we want to test more people. Once we have them, we want to make sure that they remain in treatment and don't fall out, which is loss to follow-up. So that's the second one for XTBR. So I hope that makes sense to you, because it's quite technical, but that is the underlying thinking under these two indicators. Can I go to the others or?
Yes, you may.
Okay, thank you. So then the others is then back to page 44, which is PMTCT, right? So let's go to page 44. And just to explain this to you, when it says the infant PCR test positive, were you taking, I think you were talking about the 6 months, right? Not the birth, yeah, 6 months, yeah. So just to explain this to you, so you can see here, we wanted the positivity rate after birth. Now we wanted 24 to be positive at 6 months out of a birth of about 1,500 birds. What happened is we had 2,200 birds and only 8 was positive. So this is a very positive result. Means less people were positive than we planned for at 6 months from a mother that was HIV positive. So that's why the target here is to be less. And the lower it is, the better it is for us. Did that make sense to you? Okay. So that's that one. And then I think I tripped myself up a little bit later, but page 45, it was the 18 months rate for HIV positive rate, right? This one is new indicator. I'm going to defer to Professor Mohammed. Professor Mohammed will help me with that indicator. But HIV positive rate around 18 months. I'm not sure whether that's linked still to the PCR or is the new indicator. Maybe Hassan, if you can just explain that indicator and then the actual target. Yeah.
Yeah, thanks, Keith, and thank you for the question. So what happens here is that when we look at HIV status of young children, initially during pregnancy, there's a risk of transmission from the mother to the child while the child's still a fetus, still inside. And when we do the PCR test at birth, we're measuring to what extent that has happened. And I think you've asked the question, how well are we doing in terms of preventing babies from getting HIV? So our current rate is at that, with that indicator, is under 1%. So at birth, less than 1 in 100 children of an HIV positive mother become HIV positive. Without treatment, that rate would be 30%. So 30 out of every 100 women with HIV, their babies would normally be HIV positive. But over a long period of time now, and in fact goes back 15 years with the prevention of transmission of mother to child, we've been, in fact, this is an amazing achievement, not just for us as the Western Cape, but nationally, to actually bring that rate down to under 1%. So less than 1 in 100 children of an HIV positive mother actually develop HIV. What then happens after birth is that through breastfeeding, there's the risk that a mother can transmit HIV, to her baby. And so we continue to monitor that then at 6 months and at 18 months. And we want to keep that as low as possible. So you'll see at 6 months, which Dr. Kluti spoke about, it's 0.36%. So it's less than 0.5% that of children, of babies born to HIV positive mothers who remained, who were HIV positive. So again, that's a very low rate. And then even at 18 months, where with further breastfeeding, we've still managed, although we expected 1.3% or 190 out of 14,000 to be HIV positive. In fact, I think exactly using the same explanation as Dr. Kluti, fewer, that is 86 out of 27,000 women who are HIV positive had infants who had converted to being HIV positive. Okay. So again, our rates were lower than we had expected. And again, this is a positive result. So we're in fact doing better than we expected. And despite all the difficult conditions under which the health system is currently, all the challenges we're dealing with. I mean, I think you asked a question earlier on, are we still able to maintain a good quality standard of care? At least with this indicator, we do seem to be, despite all the difficulties, able to keep the number of babies who become HIV positive at a very low rate. And I think this province with this particular indicator is performing very well. Thank you.
Thank you. Thank you, Professor Mohammed. So then the other one is on page 47. And that was all drug-sensitive clients lost to follow-up. So again, it's back to that 95 for TB. And it is this is first-time TB. It's called a drug-sensitive TB. And we want to, and you can see what our plan target was. We wanted the loss to follow-up rate to be 21%. It was in the end 23%. And again, you can see the numbers of what was there. So slightly worse than what we wanted it to be. And part of this is we are now starting to understand quite in a detailed way why people are interrupting their TB treatment. There's many social reasons. why people are not continuing the TB treatment. There's also reasons that people move around. And there's reasons that, people get a job or do something. And then for really transactional reasons, very difficult for them to get to a clinic. So we are working on this because one of the biggest things with TB is we want to pick up more TB, but we also want to keep the people that are on TB on treatment so that we can have better outcomes. So we're really working on those to improve as well. As far as I'm concerned, I think I've covered all the questions. The only one that's left is when you go to the strategies to overcome the underperformance. But just to clarify, those ones that Professor Mohammed and I explained to you is not underperformance. They are overperformance. It is because our midwives do a good job, pick up, and we are tracking that less and less people are transmitting, HIV positive women are transmitting, mothers are transmitting it to their children. Even in the breastfeeding, it's better. Therefore, when you see as strategies to overcome the underperformance, specifically go to the areas of greatest concern for us. So you'll see the neonatal death rate, why we say it was more than expected, and what it is we want to do to make sure that we do better. So we're going to something like helping midwives with SMOE and doctors. It's about resuscitating young babies when they're in trouble, doing it better. And the question that you're asking about having more midwives is obviously an essential question. And one of the critical categories of posts that we want to protect in our system is midwives. So you can imagine that you're not going to, if we have to choose between a midwife and somebody else, we will choose the midwife. It's to make sure, because it's essential that we have the right midwives with the right skills to be able to do that. And then the others, there's child viral suppression, as you explained to you earlier. And then this loss to follow-up rate is the other one, and what we're going to do for all of those. So we agree that midwives is an essential category to protect as part of bullet 1. But it's not, and we save on neonatal death rate because the other markers are relatively well protected. But midwives are still essential. Thank you, Chairperson.
Thank you, Jody. Follow-up, Member Van Voorhel.
Thank you, Chair. I'm just thinking, perhaps because the explanation is actually positive. You have done actually well in those different targets of tables. Now I'm thinking perhaps the way you phrase, you need to look at the way you phrase the issue, because now it looks like you are not performing, but actually you have done great when it comes to those indicators. So it's just an input on that. So I'm impressed with your performance when it comes to HIV/AIDS and then the TB, because TB is a huge concern, because if you lost in the system, the person get lost. He's spreading it somewhere. So yeah, I'm not sure. Do you have a provincial system or a national system, so that you can, perhaps the person just move to another town and is also getting his treatment perhaps on the other side? Is there a way that you can check if the person is back in the system or not? Yeah, thanks.
Thank you. HOD.
Thank you, Chairperson. So thank you very much, Member Van Voorhel. It is the system, the data system we have, which is in the data center, because the national system depends on us to give you the average numbers, the total numbers. So that's on the TB register. It is total numbers. The patient can possibly get lost in that. The system we have in a data center it is linked to the individual persons. There's an identifier, a unique identifier. Because we have the unique identifier system and something called a single patient viewer, we are now able to draw a line list and find the people that is popping up in another place. So it might have looked like lost to follow up, but actually the person is just in another facility, and now we can match it. And because we have it by name now, we have very positive stories, like in small towns. Actually, we saw this in Citrusdal. Because that lady got the names, she now know where to go and look and see that the person I thought is lost has popped up in the metro or has popped up in Garden Route, I now know where my patient is, so I'm not looking for that patient in the area because the person has moved. So you're right, Member Windvogel, our next development is for that line of sight across the system to be a tracker for TB patients as they move. And that's quite exciting. That's why we're also talking to the Eastern Cape, because it would be useful for us to track movements between us and the Eastern Cape. But that does bring us to a conversation about the national colleagues, because you actually need a national system to be tracking patients across provinces. But we are in development of discussing all of those alignment and integration across systems. So thank you for that, Member.
Thank you, Shodi. I don't see any other hands online. And in the absence of hands in the chambers, can we go? Member Windvogel, did you have coffee?
We are still on part B, am I right?
Did you have coffee this morning?
No, Chair. I think the HOD starts on the issue of ambulances, but I want to check on page 62. Page 62, second table. Could the department provide more details regarding the 6 recorded deaths? What happened on each case, perhaps? And then on page 73, child under point of reference, child under 5 years, severe acute malnutrition. Yeah, that's a question. I think you missed that one, HOD. The last one. Yeah. If we can touch on that. Yeah. Okay. So then I don't need to ask it again. Then lastly, Chair, on page 75, at second table, I want to know what the factors contribute to the slight reduction in bed occupancy.
Page 75. You may go ahead, Shodi.
Two. Just to explain maternal mortality, what you'll see there as well, the planned target there was 15. The actual achievement was 6, right? The deviation was 9. So what this means is we expected more deaths than actually happened. And just to explain this, we have a system of every maternal death. Maternal mortality is a very serious thing. And basically the definition of a maternal mortality is any pregnant woman that dies during pregnancy or up to 42 days. Up to 42 days after the birth. And because it is such a serious event, there's a national committee that tracks that. So every death has to have a detailed report. So we take every death, we record all the information, we submit it to this national committee. Every 3 years, they analyze it and they give us a detailed response in relation to this. But you can see this is, again, a positive achievement. There were fewer deaths than we thought there would potentially be. But there is a detailed report. It's called the Triannual Report of Saving Mothers and Saving Babies. Again, our province, we were at the national meeting, and our province were commended for having a maternal mortality that's the lowest in the country, and it's actually below the SDG, the Sustainable Development Goal. So again, our performance in maternal mortality is actually a positive story, and we do better than many other situations. So in 73, just to explain, and I apologize for the 73, the 5 under maternal, I missed that previously. Just check which one is this, Sadiq? Is this under tertiary hospitals? Yeah. So remember, Windvogel, this table here of under 5 severe malnutrition case fatality rate, we have it, the 1 year on page 73 is for tertiary hospitals. So this would now be Tygerberg and Red Cross, because there wouldn't be under 5 mortality in Grootskep, right? But if you go back, you will find another page where it is in the regional hospitals. If you go back, you find it in district hospitals. So you find this under 5 this mortality indicator in 3 different places. Tertiary hospitals on this page, regional hospitals a little bit earlier, which is the one you asked me about, and in district hospitals a little earlier. If you look across the three, the picture is that the place where we show up undernourished children or children dying because of undernutrition is much higher in regional hospitals than they are in the tertiary hospitals, which is Red Cross at Groote and Tygerberg, and district hospitals. And the reason is the regional hospitals, and this would be the George, the Paul, Worcester, Somerset Hospital, etc. Regional hospitals is where our general pediatrics service is. And that is where sick children generally land up, is in the pediatric units. So it is a mortality rate that's higher, but it is also where the sickest children lands up in pediatric units. So it is important to view that mortality versus all children and whether they're malnourished. And this is people dying of malnutrition. The worrying thing for us is that this is over the years becoming more. So if you track it year to year, it's becoming more. And because that is, we did a survey. I'll explain to you now. We did a Western Cape stunting survey last year with DG Murray Trust, or we did it the year before, but we released the results. That survey indicates that malnutrition is a serious problem in the Western Cape. It might be better than in other provinces, but it is a problem here. And the serious problem is, in that survey, that was the biggest worrying thing, is 41% of the households that we interviewed ran out of food in the last 7 days. And the issue here is this is a direct relation to children and families not having access to food, that the sicker babies land up in the regional hospitals and now starting to die more and more of malnutrition. Pediatricians will tell you, many of them, older ones, say, we used to see malnutrition quite a lot in the 1980s, 1990s. Younger pediatricians will say in 2010 towards, it was very rare to see malnutrition of children dying, and now it's starting to go up, but it is a direct result of people not having access to food, enough food in the home for themselves. And it's probably the heart-wrenching part of that survey is that adults are forgoing food so that the children can have food. So, and you know, that kind of figures is really stark for the Western Cape. So that's that one. And then the last one is on bed utilization rate, 75. I think the issue here is quite an interesting picture here, because this one is specifically for Red Cross Tygerberg and Grootskep. Remember you asked, what's the impact on Grootskep, Red Cross Tygerberg? Here you can actually see it, that if you look at the plan target that was for this year, we thought Red Cross Tygerberg and Grootskep's beds will be 77, 78% full at all times. In actual fact, it was only 72% full. And that is a direct result of the freezing of posts. I remember I answered you earlier. The same services are there, but you're waiting longer now. And because we had fewer staff, actually the beds were slightly emptier than we anticipated. It's a direct correlation to our response from earlier as well. And it is lower in real terms than it was the year before. Okay. Thank you very much, Chairperson.
Members, just as a reminder, within the allocated time for this meeting, we still need to get to the point where we will allow the public to also engage with us. And we as members, we will have another bite when it comes to recommendations. So please play ball with me. Don't make me nervous. Member Barnes.
Okay, Chair, let me be considerate. From 5, I'll only move to 3 questions. On page 75, under linking performance with budgets, one is seeing over expenditure under the central hospital services. What would be the reasons for that, if just the department can take us also through? And then on page 77, Chair, on the last sentence of the second paragraph, it states that including 63 graduate interns, in addition, a total of 1,328 bursaries were allocated to health and related professionals. What I want to know, Chair, does this include medical interns? If we can also get an elaboration around that internships. And then, Chair, my last one will be on page 100 on the Extended Public Works Program. Number of people employed and receiving income through EPWP. Why was the target of the people employed receiving income through EPWP not achieved? Thank you, Chair.
Thank you. Over to you, HOD.
Uh, 75. Just to explain what happens here under linking performance with budgets at the bottom. And it says here, when we say central hospitals, the line that says central hospitals is Grootskei and Tygerberg together. The line that says Provincial Tertiary Hospital is Red Cross. So the top line is Grootskei and Tygerberg together. The bottom line is Red Cross. And what we are talking about here is if you look at actual expenditure, you will see that in Grootskei final appropriation, actual expenditure. Yeah. So you will see that Grootskei and Tygerberg together relatively overspent together, right? And the saving that you see, the 11 million, right, was in Red Cross. So just to explain that to you, during the course of the year, what we were able to do is we were able to say that the savings that Grootskei and Tygerberg were more under pressure than Red Cross. And we could then, between the three, allow Grootskei and Tygerberg to overspend slightly so that Red Cross could absorb the saving within them. I hope that makes sense. So it is the way that we bring and reconcile across the three. There's obviously specific things that went into it to be able to allow us to get that between them. And the Red Cross's team was actually very gracious in that they said the pressures were more felt. And the thing is, you have more ill adults, whereas children are relatively less ill than adults. And that's why between the three, we could reconcile that. 77, your question goes around the interns. So what we are talking about here, bursaries in this refers to bursaries we give to students that study with us. But I think your question specifically then regards 63 graduate interns, is it? Yeah. Yeah. So just to indicate to you that in this specific, I just want to check with my colleagues. These graduate interns does not include the medical interns.
Page 97 is the medical.
So the medical interns is dealt with on page 97. But just to answer your question about medical interns, so this year is our intern program, it is our enrollment into our colleges program, and all of those. The medical interns is a different process. It is funded from a national conditional grant, and medical interns gets placed into the post from a centralized process by the National Department of Health. But just to indicate, in short, your answer is on this page, medical interns are excluded from this specific page. Thank you, Chairperson.
Thank you, HOD. Members, can we wrap it up on this part? Please wrap it up, Member Van Vogel. HOD.
Just in terms of the onerous satellite clinic, right? This specific, as I understood it, was a very underutilized satellite service. So you can see in Overberg, if you had to kind of reconcile how you do services, and my understanding of if you understand Overberg, and you understand places like Grabouw, and you understand places like outside Swellendam, all on the N2. There are different places in the Overberg where services are more needed. And if you have driven through Knoflokskraal and all of those, you can understand that actually the Overberg's growth in population is very closely linked to the N2. Right? It's very closely linked to the N2. Onrus, which is part of Overstrand, which is now that it's all the way from Kleinmond all the way to Gansbaai. And in Hermanus is the big facility that's been opened as well. It was a relatively older population, and the utilization figures were dropping, Member Van Vogel. So in terms of the bigger scheme of things, it is a service which people could easily approximate to the Hermanus, which was close by, whereas you needed to increase your capacity in other pressure points. That's the way I understand it from the Overstrand team. That's why they took the decision. And when we in Overstrand, they have detailed information of where the pressures are higher and how they redeploy their resources across the area. So Gansbaai, for instance, we went to Gansbaai. And Gansbaai, there's an increased requirement for services in Gansbaai. Obviously, in Hermanus, it also goes up. Kleinmond is relatively stable. Onrus is relatively stable. But in the area right next to, which is the Houston satellite, there's a slight uptick in services there. So it's in that whole line that it makes sense to consolidate the service and increase access in other points across that area. Thank you, Chairperson.
Thank you, Shudi. Member Barnes.
It's not a new question, Chair. It's just a reminder. My question was not answered on the EPWP targets that were not met.
Andre, you there, right? Andre, do you have the answer? On page 1? Oh, so Laura's got, oh, sorry. Laura, yeah, the EPWP. Sorry, Laura.
Yes. Okay, so if you look at the reason at the bottom, it's clearly stated that due to the, we did the setting of the target before we knew about the salary increase for the EPWP workers. So we had to readjust the numbers to what we had available. This is a national grant and is coming directly from the Department of Public Works and Infrastructure. So we did a calculation, and instead of 48 people, we could only have 41. But then what also happened in this program that is very good is the fact that the people are appointed in the program, but then they acquire skills to apply for permanent jobs. So during the year, you see there are 6 people that were appointed in permanent jobs. Usually they are appointed in government, in the handyman or that kind of position. So that is this is why, and of course we have also to deal with some other that are the private sector that can also take our EPWP workers, and then sometimes there are also people that start the program. Is a 12 months contract that we offer, but then they decided to leave it for some other reason. So that is actually the reason why we couldn't perform. Thanks.
Thank you for that response. Members, we are now at part C, and all the other committees I attended, part C was referred to SCOPA, and I intend to follow suit. I see some members nodding. So can we then go to part D, which is from page 134 until page 179. Member Van Vogel, take the lead.
Thank you, Chair. I will try to keep the committee busy after our session.
No, we're a GNU, remember?
You are actually forcing me now to cut my
Remember, we're a GNU, some more.
Yeah, Chair, mine is on page, on part D. Page 168, the foreign workers by major occupation in 2023 and 2024. What I notice about the department is that actually this department is probably employing the highest number of foreign nationals in the province. What are their countries of origin and what scarce skills are they bringing? And then secondly, Chair, I just want to check on page 174, and it speaks about point of reference type of misconduct addressed in disciplinary hearings. Could the department provide an overview of these type of misconducts? And are there any cases worth sharing with us? Then lastly, Chair, could we also on page 175, grievances lodged in 2023, 2024, could you also provide an overview of grievances lodged and what are the details of disputes that were upheld in favor of the employee? I will park there. Thank you, Chair.
Thank you, Member. HOD, over to you.
I think, Member Winfrey, you're right. In terms of foreign nationals being employed by our department, you can see that as of 31st March 24, that we are talking about 158 people in highly skilled supervisory levels, right? These are mainly referring to medical personnel. So it's mainly in the medical field, which is highly specialized. So it's doctors, specialists, and it's mainly in that category. The other categories are of lesser importance, but you can see the big reason is 84% of all of the foreign nationals are professionals that work in our system. I can go into detail, but it's professional workforce. And if you want to understand that, you need to understand it within the context of the global movement or phenomenon that the biggest mobile workforce in the health systems globally is professional staff. And if you want to go to a country like Germany, you will find a lot of South African nurses in Germany, etc. You want to go to Canada, you'll find a lot of South African trained doctors in Canada. So there's a thing about global movement of professional staff. Because they're mobile, the skills is transferable. In our setting, which I always remind people, is South Africa is quite an attractive destination for people from other countries to also come to our country. So as part of the global movement, you will always have a mobile group of people. And how many people of all of us can say, anyone in professional field, me and Dr. Karim will tell you, people in our class, how many of us are actually in South Africa and how many of our classmates are working all over the world. Doctors, specifically doctors, but now also more recently, professional nurses, and especially specialty professional nurses, is a highly mobile field of categories. That's just our picture within the bigger picture of the mobility of highly specialized staff. If I go to 174, if you talk about the misconduct cases, 174. But if you look at the misconduct cases, I think your question, so this is a breakdown of what the kind of misconduct cases are. Again, you will see that the majority of the misconduct cases is desertion. Sorry, am I right? No, it's dismissal. Yeah. So obviously from dismissal, and then it's followed by the other categories. Your specific question is on page 75 is when there were disputes lost and how many were settled in favor of the department, upheld in favor of the employee, and dismissed in favor of employer. So you will see that the 49 cases was upheld in favor of the employee. And that is specifically disputes lodged with the councils. So what you need to understand of this is everybody has got the right to refer an outcome to a next level. And this case is to the council. And then there's a fair process to uphold and look at what the merits of the case is. And then it's either upheld in terms of the department or it's upheld in terms of the employee. And in this case, you can see that the majority is actually upheld in favor of the employee. This is a sub-selection of cases that goes, because you need to also understand not everybody where there's been a settlement actually refers to the case. And it is on technicalities. Most of the cases is on technicalities where it's upheld. And it's not necessarily always on substance of the case, but it's on the technicality of the process that was followed. But there's detail, and Mrs. Aris and the team has all the detail for that. I think I've covered those questions. Thank you, Chairperson.
Grievances, 175.
Conduct, but then grievances on top. So I think the issue of grievances, you will see that in terms of the 203 grievances that were lodged, that 95%, which is almost 50% of grievances were all resolved, which is a good place to start off from. That's almost 50% of your grievances is resolved. The balance, which are 26%, is not resolved. And that is where there is a process, but because the grievance procedure allows for appeal and extends the process, so it's not resolved. And then there's the ones that is still pending, which again, because of the length of things, it might be that the grievance was registered in the last 2 or 3 months, and it's not within the time, and that it still has to be pended. What we've done over the years is to strive to get as many grievances as possible resolved. That is a huge achievement. And the team in Mrs. Aris's office, our labor relations team under Advocate Small, have made huge strides in the last 3 to 4 years alone in terms of getting grievances resolved. They're also following through on the disciplinaries, they're following through on the misconduct. So our performance over the last 2 or 3 years has been a dramatic improvement in following through. So as you watch this, and if you're going to be in a committee for a couple of years, you're going to see the movement in terms of the movement in relation to all of this. Thank you, Chairperson.
Member Van Vogel, follow up, then Member Barnes.
I think the HOD partly covers me, but I also want to understand the type of, so that we have an understanding.
The types, Mrs. Aris, it's normally, I'm going to ask Mrs. Aris just to give you the highlights of what kind of things comes as part of the grievances.
So the grievances, the type of grievances, people being unhappy about salaries, about being promotions, about filling off post, about being unhappy of not getting grade progression, being dissatisfied with something in that line. And sometimes it's about a behavior of someone that they didn't like, obviously harassment and those things. So those are the areas that we then would investigate as a grievance, because people formally lodge this and therefore it will be investigated.
Just add to that, member, Ms. Aris is saying, because of we have analysis of this. What is heartening to us is the grievances around workplace bullying, the grievances around victimization, the grievances around all of harassment, that is proportionately decreasing, which is in line with our culture thing that we said earlier. The grievances here is mainly about work conditions, getting access to promotion, getting access to training, getting access to be, I'm asked for this and I wasn't given this. So it's more about working conditions rather than about, let's call it the negative aspects of harassment in the workplace. Thank you.
Member Barnes.
Thank you, Chair. Perhaps my first one will be following up on the question that Member Van Vogel asked on the foreign nationals. Or in terms of their compensation, do they follow the European standards or is it South African standards? Just clarity on that one. And then my original question is just one. It's on page 178 on the book. Under injury on duty, one can see that there's one fatality, which I would assume someone died on duty. And the second one is permanent disablement, which is 44. if perhaps also the department can bring us into light as to what is the status quo, what happened, so that we can all have a clear understanding of the working conditions of the workers there. Thank you very much, Chair.
HOD.
Thank you very much for that question. So the first one's very easy. When we say foreign nationals work here as professionals, you can only work and practice in a professional capacity if you are registered with the Health Professions Council and you meet the criteria of functioning, practicing here. So if you want to work here, you must be registered with our local council, and your qualifications is vetted and it's in line with the standards for this country. So it's a very simple procedure. We don't employ anybody that is not properly registered and have the appropriate qualifications to function in our context. On the issue of injury on duty, the injury on duty issue is obviously it is very painful when we have a fatal injury on duty, and we know specifically what that incident is. But also it is painful that we have disablement in terms of the duty. Now you must take that 144 out of a workforce of 33,000. And many of the members would have come across the perils of working in our system. You know, so you can imagine what it must be to work in an EMS and what it must be to drive in an ambulance and go into these dangerous areas. I suspect that one fatal was that case, was it? Yeah.
The fatal incident is someone that actually passed on the sports day.
Oh, that
yes.
was the fatal injury. Yeah. Okay. Yeah.
So maybe.
Yeah. Actually, yeah. So maybe that was very sad case of a person that was very fit. It is it's work in one of our facilities. We went to the sports day, Western Cape Sports Day. The person actually came second in the 100 meters dash for men. Felt unwell, collapsed, and passed away. And so again, that was just for us a reminder of the importance of health and wellness and looking after yourself. But that person was a fit person, and by all accounts, an athlete, and it happened. So that's the member bonds. That is that one specific case. Mrs. Aris can speak about the permanent disability. Yeah.
In terms of the definition, it's 44 staff, 425 staff members that was temporary or for 14 days. And it was accepted by Department of Labour as a COIDA case and registered as such. And then permanent disabled is where where it's more than 15 days. And where, again, in terms of the Department of Labour and the COIDA, it was accepted as an injury and the person has been off for longer than 15 days and more. In some cases, they would, through our ill-health process, then go off on retirement. And they get special leave. Yeah.
Is the majority of that 44 in which kind of categories?
So I have the list of names, but it's a range of, and in this instance, it's mostly, or most of these numbers are from our EMS category, our emergency care practitioners that is due to an incident at work, and that has been off sick or due to stress, but also physical injury.
Members, may I suggest that some of the details we can request that when we get to recommendations. And members, as of now, please look at my facial expressions. Member Van Vogel.
Yeah, Chair, it's just a follow-up on the foreign nationals. Does it imply that we don't have such skills in the country? Why? Because the reason why I'm asking, if I'm not mistaken, was it early this year or last year, there was a huge issue when it comes to unemployment, when it comes to our doctors and nurses and what. So the skills that they are bringing, is it a scarce skill?
HOD, and we're going to wrap it up on this one.
So I'll make it very quick. There are, for instance, programs and areas where we give preference to South African graduates. So we're very clear how we give preference to South African graduates for certain areas. These are mostly areas of skills that through a competitive process of finding the right candidate, the foreign national is the best candidate for the job, right? Because of they bring specific skills, and it's mainly in the highly skilled arenas where we do that. But I can assure the member Windvogel, I can assure no South African highly specialized person is denied access to posts because of a foreign national. You would have heard that. You would have heard that over and over in the newspapers if that was the case. So no South African is denied access to any highly specialized case. And it's mainly on the basis of the skill set and the availability of people at a specific time for specific posts.
Thank you, HOD. I don't see any other hands online. Going once, twice, thrice. We close off this part. Members, we are supposed to be at part E and F. And once again, the practice is that stands over for SCOPA. So I have reached the pinnacle point of this session, and this is where we get some inputs and interaction with the public. And it's also one of the areas where we get measured on how we're doing as a department. I am now going to give an opportunity to any member of the public would like to interact with us, comment, make submissions. And in the process, if there are any hands, please state your name again, and so that we can record it accordingly. Members of the public. Mr. Pito.
No, thank you very much, and also to giving us the opportunity. And I have only three things. Number one, in terms of the service delivery, particularly in Kraaifontein, because I see in Kraaifontein, particularly in day hospital, there is three things there. I think this is a major issue. Number one, the number of patients in Kraaifontein is huge. They come in for 5 o'clock. In 4 o'clock, they tell the patient we got 2 doctors for today. We can come tomorrow. Number two, in terms of the capacity, because Kraaifontein is where area they develop every year. We can check or we can test these things. Number two, I'm not sure in terms of what is the procedure they implement that you cannot have a right to call the ambulance, whether we're very sick, whether what problem we have, we can from Kraaifontein till Kalbrema or Tigerberg. It's only that you must get a referral letter from day hospital to Kalbrema. But if you can just pass in the hospital, they will never help you because they says we are staying in Kraaifontein. Lastly, we can check in terms of the trauma room in Kraaifontein Day Hospital. In the clinic, also called by Blokombos area, doesn't have even a X-ray because the cells is only check a small children, I think age for 0 to 12 years. But if it's not even X-ray where we can be operate our children or check our children, I'm not sure the official or the province under the department at Kraaifontein is where he can check in terms of how to help those issues. Thank you very much.
Thank you, Mr. Pito. Any other hand? Mr. Sylvester.
Thank you very much for the opportunity. Appreciate it. I just want to refer to an institution where or facility where, to me, TB and HIV is so vast in the Western Cape. And I found that there's little awareness being done on those illnesses. I feel that the health promoter is not speaking to our community. I hardly have seen a health promoter for a couple of months speaking to make awareness. They short staff, the queues are long, why they can't see a CNP and they want to see a doctor and that kind of thing. And it's very important. That causes a lot of conflict in the facility because the people get upset. The hours has been long waiting for us to see a professional doctor or a CPN nurse. The other thing is my concern is about a school nurse going out to the schools regarding to pregnancy or any other issues that the children have. Do they report that back to the facility so that there is big awareness of what's happening in the schools with our children? I'm also concerned that in the facility, in the past, we 14 years later, again, yeah. So in the past, they used to put up stats and identify so many people as HIV and diabetes and things. That's where the health promoter must come in and make awareness to our public or to our community so that they, in order then go back to the community, their neighbors, their friends, and inform. That's how you spread the word. So that for me is very important. And I hope that going forward, you know, that our community needs to be taken care of. I know there's a lot of challenges and things like that, but every year we speak about similar things. And to me, I don't see going forward with this whole things that's been laid on the table here today. I just wish that our community mustn't suffer so bad because we are in a situation where we suffer tremendously. Poverty, food prices, and not eating well, obviously, because then you can't look after your health. I do thank you.
Thank you, Mr. Sylvester. Mrs. Kivitz.
Thank you, Mr. Chairperson. I have quite a few. That's why I prefer to go last. Page 4.
The best for last.
Yes, page 4. In the minister's forward, in paragraph 4, the laundry services. The refurbished, God help us, the refurbished laundry at Tygerberg and the distribution of laundry. Because for the hospital, and I'm specific, I can only speak of one hospital. I can speak of 3, but I will speak about Tygerberg. When the patient doesn't have a sheet to cover the mattress, the patient is told that the staff cannot help for what happens at the laundry. So which means that if Tygerberg sends 1,000 sheets to the laundry, does 1,000 sheets go back to Tygerberg? So is there a clear indication of the distribution of laundry services to those that are the drainage area for the laundry at Tygerberg? Then on page 5, the last paragraph in the accounting officer's message, it says the department continues its strategic journey with our central strategy. Health is everybody's business. Added to this is our service redesign strategy, which will move us towards a resilient health system capable of thriving in polycrisis. Nowhere in this report, and this is the second year, and I would like the portfolio committee to note and something needs to give. Nowhere in this report is mentioned about the statutory bodies. That is our health committees and our hospital boards. So if health is everybody's business, and everybody includes everybody, but those bodies are statutory bodies. There's legislation around it. And so nowhere does the department in this report indicate the functioning and non-functioning of hospital boards and clinic committees across the province. So the portfolio committee, you never get us back, so we would like to come back. We would like you to get us back on health committees and hospital boards and the functioning thereof in the absence of reporting. Then on page 7, just a question of concern, because if there's a surplus of 52 million and the under expenditure of 92 million, it gives us 114 million in total. So if there's a surplus, it means that that's money not spent. Somebody is saving that money, maybe bonus, or somebody gets recognition for that saving. And then the under expenditure that I also understand is that, and the department explained it. However, if you look to service delivery in our facilities and in our communities and cross-cutting cost effectiveness, how do we get to these two totals if the department can explain that? Then on page 9, the discontinuing of activities. I mean, George Hospital services quite a number of people, and so do Paul, because it's a vast drainage area. So how was the community informed about the discontinuation of activities? And if health is everybody's business, I think the community voice in ensuring service delivery effectively should be key in all of that. Then on page 10, the new proposed activities. And so just proposal for infrastructure changes at Ceres Hospital and Worcester CDC. My concern is the Ceres Hospital. The community of Ceres was promised in the previous financial year that there will be a possibility of looking at the vacant private hospital to occupy for better services. So if we're going to put in infrastructure at Ceres Hospital, does that mean the promise made to the community of Ceres will not be fulfilled in looking at the services moving to the private facility? And then on page 11, the forensic services. And this was my question last year, and it will be my question again this year. When will the commissioning of our forensic services in observatory be finalized? We have been struggling for the past, I think, I don't know how long I'm coming, but I almost think it's 20 years. We've been struggling with Salt River, and now we're struggling with observatory. So when will the commissioning, full commissioning of observatory take place? Then on page 13, and I think that was member Van Vogel's concern with a forward, and mine would be if there was no event reporting post the printing of this document, is why is the new MEC forward not an annexure like in previous years when there's a MEC coming in after the reporting date of the AR. Then on page 14, yeah, gosh, The second paragraph in the conclusion, the unpacking and unfolding of financial reality of the term plan healthcare 2050. There's no mention of healthcare 2030. And that would be the next 5 years of the department. And so how collectively are we co-creating what we have promised in healthcare 2030, going to healthcare 2050? I think I would want to ask more questions, but I'm going to leave that. Thank you.
Thank you, Mrs. Kivitz. Mr. Pito.
I want to ask the question. I'm allowed to ask the follow-up question.
No.
Yes, I'll allow you depending if you're not happy with the responses.
Okay.
HOD.
Thank you very much, Chairperson. So really just to thank you for the colleagues for raising these questions. I'll start with Mr. Pico's questions. Sir, your point about the number of patients versus the capacity at Kraaifontein, we are very familiar with that. It's a big drainage area, and to match the capacity with what the service need is a concern to all of us. The second thing about procedure, about referrals to the next level hospital, which is called Bremer Hospital, and why procedure of referral letters are important. And then what is the service offering that you can do in a trauma unit that's 24 hours, and the issue around X-ray. So Kraaifontein drainage area, like any other big 24-hour CHC in the metro, is growing disproportionately, mainly because of the growth that straddles the entire Kraaifontein drainage area. So if you start with Wallisdean and you start with Bloekombos, you go to Scottsdene, the new big area around Durbanville and behind Santakral, with new developments in that area. So Kraaifontein has a broad drainage area. Of all the 24-hour CHCs, Laura, the Kraaifontein has had an upgrade on the east, the entrance part, the pharmacy, and the ARV area. Yeah. So what you need to understand is the Noon was built as a similar facility. You have Vanguard as a similar facility. You have Retreat as a similar facility. You have Mitchell's Plain as a similar facility. And now in Hanover Park, we will have a rebuild of Mitchell's Plain, of Hanover Park. You also have Elsie's River as a similar facility. So when we look at Kraaifontein comparatively with all of those facilities. And one of the things that we are looking at and realizing that what happens in the drainage area of all those metro facilities, one of the biggest thing is, what is your footprint in that drainage area to take the pressure of a place like that facility? And it's repeated itself in every place where we go. Site B is the other big one as well. So Chairperson, the whole idea is to deal with the workload and what happens there. You need more capacity away from Kraaifontein to deal with the issue so that there's less pressure on Kraaifontein. And that's why the Santakral facility, it was run by the city. It was one of the 10 facilities that was provincialized to us. Scottsdene was one of the facilities we've had conversations with. So in that drainage area, one of our big things is to understand what is the footprint and the facilities that can take pressure off Kraaifontein. And that is where we need, and community-oriented primary care becomes an important thing, is where the community health workers are. What are the kind of things you do in the wellness sites, where we can have pickup points for medication, and the churches and all of those. So it is a big undertaking that we should be thinking collectively about making healthcare more accessible to people where they live than them having to come to Kraaifontein. So that's the first big thing. The thing about having referrals to the next level. So if Kraaifontein is under pressure, Karl Bremer's drainage area, it's Kraaifontein, it's Elsie's River, it's Delft, it goes up in terms of others. So your pressure escalates up one level when you go to the hospital. So that's why what you need is you need to build in that people need to be seen at the PHC facility and get a referral to the hospital. Otherwise, your hospital will be overwhelmed by people coming in. That's part of our staggered system that we have to build and we have to be rigorous about. And therefore, again, it is how do we actually make that system work smoother? And the idea is if people are coming to Karl Bremer for the wrong reason, how can we stabilize people in Karl Bremer in their OPD and make sure that they're seen at another level so that the people that need to get to Karl Bremer quicker can get there quicker? So again, that is what the team is doing in that local area. And then what services is rendered on a 24-hour basis is actually quite a important thing for us to consider. Now, Kraaifontein is one of the places that has a 24-hour maternity service. So it runs a MOU service in terms of this. It also runs this 24-hour trauma unit. And I think, Laura, that is the point, though, about the trauma unit. That is probably the one area in Kraaifontein that's not been expanded. That emergency center has not been expanded. So if you take at the developments, the pharmacy is expanded, the waiting area has been expanded, the actual emergency center room has not been expanded. And then the other big thing, which is access to x-rays, is a broader challenge we have because it's not the x-ray facility, it is having access to radiographers that can actually run the service. So all of those things is intertwined, but we are very much familiar that like in Kraaifontein, like in Delft, like in all the other places, there are similar interventions about strengthening what happens closer to where people live to take the pressure off a place like Kraaifontein. When it comes to Mrs. Sylvester's question, Mrs. Sylvester, I must say to you, I would really like to start with your last point, because that is the reality. So you, I guess, like most of the people in this room, hopes that the community challenges can get better. The challenge is the community challenges are getting worse. And the reality is, as I explained about the malnutrition, there is less food for people at home. There are less jobs. The challenge is because those things happen and those are social drivers, the healthcare system has to absorb more. And if you now put the healthcare system under resource constraint, the need is being escalated all the time as long as the social factors are there. So as long as there's inequality in the household, as long as people don't have access to food or jobs, as long as the poverty gets worse, the more need is going to be serviced on the healthcare system. Now, we share that concern with you. That's why I'll come to Mrs. Kivich's questions. That's why us working with other sectors, where those social drivers become very important. It is about saying, unless we turn the drivers off, there will be just a never-ending need of healthcare need coming to the health facility. And it really, with yourselves as community activists, it's quite important that we actually find a workable solution of how we together put the pressure where it needs to be to make the difference. I agree with your point about using data display and sharing what's happening in the facility. I think that's a very powerful point. Because if we can tell communities, this is the burden we see, and not just the burden we see, but actually these are the drivers of the burden. It helps us with our efforts of informing communities that what comes to the health facility is just a microcosm of what's happening in the community, so that we can communicate it more effectively. And it would be very useful, seeing that you are a member of that complex facility board or clinic committee, be useful to see what would be a useful model to use that communication in your specifically Heideveld area. And I think it would be quite an exciting project to find out what that would look like. I agree with you with the school nurse going out. Teenage pregnancy is probably one of the biggest worrying things that we have been keeping an eye on. There's a very staggering statistic that we see in our quarterly data. And that is the number of pregnancies or the number of births to girls that is aged 11, 12, 13, and 14. It is a staggering, it's small comparatively, but it's a number that every time we look at the data, it jumps out at us. And actually, again, as Ms. Kivitz is asking, this is probably one of those things that we are going to use as a marker in our last 5 years towards Healthcare 2030, is to say, what do we all collectively do about 11, 12, 13, 14-year-olds falling pregnant? Because it is a marker of youth access and youth aspiration or youth hope. So that is a very powerful marker. The education department has actually approached us, and they've said to us they want to know and work with us, specifically targeting that 10 to 14-year-old age group. So we are going to do something quite exciting with the education department and try and raise it. But it's going to throw up a whole lot of stuff, because we're going to have to engage the school governing bodies. We're going to have to look at what it means, because everybody is trying to say you shouldn't be targeting that group, because any attempt would be that you are condoning sex. But we have to deal with the reality that babies are born to children of that age. But TB HIV awareness in the health facility, it is a very, and the role of the health promoter is a key role. So it is one of the challenges that we are recovering with. And one of the things that happened is because the facilities and all the resources was under pressure, invariably, and I'll come back to that question about the underspending in the post. Invariably, because people wanted to keep the nurse and keep the doctor, invariably, essential people like a health promoter then kind of gets caught in the wash. But that's an essential job. It's about communicating with people while they're there, communicating with others, so that we do. And I agree with you that having those messages, engaging people is quite an important function of what should happen. I'm assuming everybody knows you're talking about Adafeld CHC. So I'm working because I know that that's what you're referring to. Ms. Kivitz, just to indicate to you, page 4, the laundry service, there's a very clear distribution system. And between that laundry service, it's punching way above its weight. The distribution is even now as far as Cape Winelands. It's looking after Ceres Hospital. And whenever we go to that place, I just come back completely astounded about how well that laundry functions. Now, if there is a distribution issue and at the facility or ward level, there is a mismatch, it is within the system at Tygerberg Hospital that we need to understand why is a place running out of laundry, and then using the excuse that it is the laundry service. We need to track and see where that is going wrong. I, for one, know that when we were there, I mean, that system, I don't know, what is it too loud, 1 million pieces? 1.7 million per month. It is the busiest and the most efficient laundry in the whole country, private and public. And people are coming from other provinces to come benchmark around it. So it's a very sophisticated distribution system. But the laundry itself is very much dependent on what they receive from the facility, be able to put into it. And they explain to us actually where the leakages in the system would be, because you can only respond with what comes in the bag that arrives at your place. So if there's something going wrong somewhere, there's an institutional responsibility to track what happens or what actually gets delivered to the laundry, rather than assumption made that the delivery the laundry is at fault. But it is a very sophisticated system. Health is everybody's business. Very much important point that you make, Mrs. Kivitz. And statutory bodies are not reported on in this book, Chairperson, because this book is prescribed. If you had to read this book and think this is the only thing we do, this is not the only thing we do. This is us reporting in a prescribed format what we do. And at any time, at any given time, it is a snippet of what we do. How many times this morning did we refer to strategies, to things, to broader things that's not written in the book? The same applies for statutory bodies. It doesn't mean if it's not in the book, it's not important. And therefore, this book doesn't allow us to tell us what our progress is with Healthcare 2030. But we have an entire technical review committee under Ms. Nkosi here with experts, Professor Gilson, Professor Snyder from UWC, and we're doing an extensive review of how far have we come with Healthcare 2030 and what we need to do in the next 5 years to realize the promises of Healthcare 2030, which includes our engagement with statutory bodies. The Minister has got a very specific interest in that. We've briefed her, and there is some exciting things that we want to bring under her watch to the Standing Committee about reviewing the regulations to make the statutory bodies more effective. But that does involve a consultative process to take everybody along. So we agree with you that statutory bodies are crucial in terms of this. Again, page 7 was Kivitz. I think we did explain the surplus, that we said it's a half a day's expenditure of the department. And it's a technical exercise to show that. And that surplus and all of that is a double count. We're talking about 97 million. And we explained earlier this morning that it literally is half a day's expenditure for our department. And it's technically, and also what people come into at Paul. And therefore, it was carefully selected. There is a facility board, and therefore she's right. Whenever you are going to do things like this, there's a communications thing. That's why it's not preferable to have mid-year things as a quick crisis. You need to be able to talk over a long period of time, and we should never, ever be faced with a situation that we must make quick decisions in a space of 2 or 3 months. So we agree with you. I can happily say to you, the observatory facility, forensic pathology service is functioning from the 1st of October last year, is it? 6th of October last year. And it's functioning quite effectively. Yeah, so it's functioning in terms of what is at Salt River. That's why earlier we said we had to get out of Salt River, close it because the buildings was not effective. So the service is run in the observatory forensic pathology service. And it is a good service it's run there. The only thing that's outstanding, because this is a thing that we had, it's a complex facility with highly technical laboratories and things. The only thing that is a drawback for us is the laboratories must be fixed. So we're literally living in a building that's quite fancy, and we're doing a service, but there are some technical things that still needs to be fixed while we are rendering the service already in the forensic pathology service. In terms of Ceres, the commitment in Ceres is to do adjustments to the Ceres hospital, in addition to what is happening in the 24-hour.
Yeah, just to clarify, we bought the neck care building, was done last year, and so we bought the private hospital, and we are currently upgrading to become the CDC, the Community Day Center for Ceres, and then we'll free up some space inside the hospital to make the hospital more functional. So we did what we were planning to do. Thanks.
So, and it is in consultation with the local community structures, and it actually is a very neat solution to the challenges that was in Ceres. So that building that was the old Netcare building, was it Netcare? Is now becoming a community day center, and actually takes a lot of pressure off Ceres Hospital. So it functions with a doctor, it's got rooms and all of those, and therefore less pressure on Ceres Hospital. And because that is so, Ceres Hospital's internal configuration can now be adjusted. So that is what the Ceres plans are. That's page 10. And then page 18, the new minister in an annexure. All we can say is, I think Minister Wenger tried to explain that in terms of the statutory timelines, this document was finalized with its timelines prior to the confirmation of the MEC, the minister arriving. And obviously that is what is bound and put in front of you. Then in terms of page 14, the issue about Healthcare 2030, you will see in page 14, we talk about the next 5 years. Okay, so we talk about a 5-year plan and we talk about Healthcare 2050. The next 5 years is the last 5 years of Healthcare 2030. And as explained earlier to you, we don't go into the amount of detail that's required. When we bring the 5-year plan, the question would be, how does that 5-year plan give effect to the last 5 years of the Healthcare 2030 commitment that we've made? And then out of that, in the next 5 years, how do we develop a Healthcare 2050 plan in consultation with everyone? Thank you very much, Chairperson.
HOD, before you end off, I think Mr. Peter also referred to, if I understood him correctly, with not being able to call an ambulance without the referral letter. Or did I misunderstand you? Or referral to the hospital? Okay. Without the referral letter. Oh, okay. Minister, that you wanted to add? Oh, okay. Follow-ups, Mr. Pito.
Yes, thank you to give me this opportunity again. I got two things. I think the HOD will be answering me. Number one, ever since the former minister was taking the office, the says we can build a bigger hospital in Kraaifontein like Khayelitsha Hospital. Today, never built the hospital. I'm assuming will maybe says ever since the land was identifying now is the informal settlement. Number two, there is a people who so-called by home-based care. They're doing a great job in our communities. Great job. But ever since also may I get a clue in terms of their health. Those people are working, those home-based care is not growing. The reason why I said it's not growing is probably it's working just community. But there is a challenge, our clinics, there is a challenge, our hospital day. I'm not sure Department of Health, it can be maybe creating some learnership where it can be learning further. After that, it can work under our clinics and also the hospital. After that, they can recruiting other people, because I think health in this country is one of our priority, particularly after us who are under the COVID-19. You understand? We see a lot of things there. I think, Chair, is only those two questions, because to me, it's very important in my area. Thank you to getting also the opportunity, including the whole parliament. Thank you to give me the opportunity. Thanks.
Pleasure, Mr. Pito, HOD.
Thank you very much for that question, Mr. Pico. So what you're referring to is a plan called the Northern District Hospital. So part of what our plans for the next 10 years is to prioritize Belhar Regional Hospital, prioritize Klipfontein Regional Hospital, prioritize a new hospital in Helderberg, and after that comes the Swartland and the Northern. So that's the five, I mean, besides the Tygerberg PPP, which is a massive institution. So we have a program that potentially will take us to 7 new hospitals, but obviously we need to understand within the context of where we are, which are the sequence of those. So the hospital you're referring to in our books is called the Northern District Hospital. I think we have a site.
The site, as the gentleman mentioned, was during the beginning of the lockdown, was in Bloekenbos, close to the N1, and it was invaded. So it was a provincial government site. So we lost that site, and now we are looking for alternative solution.
Yeah. So the issue is that it is on the radar. It is just how soon we can get there. So the fact that we're saying that it's on our plans, it's part of those plans of hospitals. The second thing about home-based care is quite an important thing that you make. And what we need to look at, I spoke about community-orientated primary care. So it's a big term, but it is where your clinic, like a Wallisdean clinic, right? And the community health workers that functions from that clinic becomes a unit, and we see how do we work more effectively in all of those areas, as opposed to the Scottsdene clinic and the community health workers that's in that area, as opposed to let's get the one outside. Anyway, for Santa Cruz and what is there. The challenge that we have is we have got a program, and Mrs. Aris and the team actually do have it, where we are looking at what community health workers are trained for. And we have a progression of what the community health workers. We actually have multiple stories of how community health workers they become enrolled nurses, they become pharmacist assistants, they become rehab care workers. So there is a career path for community health workers. It might not have been clearly articulated to you, but there is quite a sophisticated system that people can come in and they can migrate into other jobs. And obviously what we need to get right is to get that footprint right and look at expansion of that footprint so that people can move through that system into the bigger system. So we agree with you, and that's part of our strategy. Thank you, Chairperson.
Thank you, HOD, Mrs. Kivitz and Mr. Sylvester. I'm going to have my one-on-one with you during lunch. Members, we know the drill. HOD, I'm going to start with you with your closing remarks, then you, Minister, and members, we will then remain behind. HOD.
Chairperson, thank you very much. As always, I would like to thank the committee members. We really take this accountability to yourself seriously. I started off to say we come to you in humility. We come to you hopefully that you've experienced not in a defensive manner. And we genuinely come in with a sense of asking you to provide your oversight and for us to gain from it. And in that spirit, I would really like to commend you for the maturity of our engagements. I really appreciate the manner in which we can relate to one another. And the team and us, we definitely will take forward seriously the issues that comes out of the deliberation. So thank you for that opportunity.
Thank you, HOD. Minister.
Thank you. Let me start by thanking members of the public that took the time to come to this annual report session this morning and for making your inputs. We're very grateful for them. Then thank you to the committee for the oversight role that you play and for asking the tough questions. This is a critical part in the oversight role that you play over the executive and its work. Thank you very much, Chair, to yourself and to the committee support. We're very grateful for a very constructive session this morning. Thank you.
Minister and HOD and the members of the public, thank you very much for the engagement. It was very constructive. And Minister, I don't know about you, but I'm going to write this day and date as our baptism, the two of us. Lunch is served. We will join you folks shortly in the members' lounge. Thank you. Thank you, HOD. So remember, yeah, lunch is served for the professionals as well as the members of the public. We'll join them now. Pito. Pito. Members, thank you very much. It's their time of the program, time for resolutions. I had quite a few resolutions as we were asking questions and debating. Can we then just remind ourselves or dot it and see whether Nomonde have got it the way we have put it? Resolutions. I remember the first one was a list of the 47 clinics where they install generators and inverters to the amount of 25 million rand. We need that list.
No, it's already, I submitted to the members already, the department forwarded.
Oh, so I'm the slow one.
We got the list, Chair.
Oh, thank you. No, thanks, guys. I'm the slow one. All right. Then also, I have a resolution of my own that I'd like to recommend. We need to visit this laundry when we're going to do our visiting list in future. You know, I think we need to include the laundry as well, the Tygerberg laundry. And then what else was there? Also, I've got another recommendation that I'd like to propose. They spoke about an EMS college that's producing ECAs. I think we need to put that on the list as well. Member Van Voorhel? Mhm. Yeah. The health committees and the hospital boards. Okay. Okay. Is that LBC you mentioned? Yes, you can. Member Walters? You said LBC something, but we'll be able to track it. Member Walters?
Chair, then I think the issue of the disruption to the budget and the consequences for it. There were three major factors there, and I'm actually quite, as you could see, I was quite animated by it. It's how do we protect and I think the department should report back what steps have been taken to prevent us from mid-year or mid-budget budget cuts, and then secondly, not being undercut by financial decisions elsewhere in government. I think it's frankly an issue that every province in the country should be worried about. And then a last thing, just to add on to what Member Van Voorhel was said, that issue with the hospital boards, I think is very interesting as well. I support a resolution. Just as an interesting note, I was Googling while the Ms. Kiewitz was speaking. There was a discussion like this in the 2020 Health Committee as well. It's not a new matter, and it could very well take the form of an update of comparing where we were in 2020 and where we are now. But it's something that as a newbie in the committee, I would also like to understand better.
Member Van Wyk and then Member Van Voorhel.
Yes, I think just adding on to Member Walters on these austerity cuts that they had to undertake, that we need to understand what they had to take out, what is that damage and what is that impact of the austerity that they had cut, and how and what needs to be done in restoring that level of health service. So I think it is that, and those of us who were on the site visits will remember in Oudtshoorn Hospital, there was that sort of indication that things are sort of okay, but we are almost very close to a lot of stress within the system. And that's part of that whole austerity, that it's having an impact on the staff, and there's an impact then on all of the goods and services in that entire operation of the health system. And, you know, to what extent this austerity cuts have caused that damage that we have seen, that we can try and incorporate that into a report that we can understand that.
That is noted. Member Van Vogel, then Member Barnes.
Thank you, Chair. No, Chair. I'm just worried that my mic was off when I make the proposal. When it comes to the company called LBC Multi-Service. And so, yeah, I propose that we take it to SCOPA. Then, Chair, the other issue was in terms of reclassifications of facilities. In the report, they mention, because you asked us to cut our questions, they mentioned that the reason for the closing down of Elfin Clinic, Ellens Bay Clinic, and Wapperpool, is it Wapperpool Clinic, and opening them as a satellite clinics. How did this affect the service? I want to understand, and why was Knysna subacute intermediate care reclassified as an NPO? If they can give us an explanation why, when it comes to Knysna, why was it reclassified as an NPO? That's a subacute intermediate care. And then I also want to understand these reclassifications of facilities, the reason why. I think I will park there. Thanks, Chair.
Member Barnes.
Thank you, Chair. Just a short one. I think I've asked the question on the designation of workers, the number on the lower level. It was not indicated in the book. They only show senior management going down. There's nothing. If perhaps we can get a submission on the number, because I've noticed there's a high number of, especially paramedics, that are resigning. If they can give us closer detail as to why, and yeah, the number of that, if we can get a list of that. And then I'm not going to wait for SCOPA. I want to align myself with that
LBC.
With the LBC. I've also raised it in the meeting where I said, Chair, that if you look at the time frame, December, this application happened only 2 weeks ago. They are picking up discrepancies. Perhaps if the department can also make a submission to us, because my question to them was that didn't supply chain just pick up anything? If they can give us as to what are these problems or the discrepancies for us as a committee, give a submission for us so that we speak of something that we know, because now it's broad. So we as a committee would like to zoom into that. Thank you very much, Chair.
Member Jacobs, wrap it up.
Yeah, thank you, Chair. Chair, also just one thing is the department might look into the matter of those companies that was red flag, those companies that is, you know, when it comes to say like with the city of Cape Town and other departments where that companies was red flagged for fraudulent dealings and corruption. The department must also make sure that they look into that so that we don't make that same mistake. You see, tomorrow, then this department or this sector that we're on is in the papers again for, yeah, there's companies that is red flag and they're getting tenders and they say, hey, but all of you, you're sitting on that committee, how come you guys didn't pick it up? So it's very important. And then the other thing also, Mr. Chair, I just want to bring to the attention of the House is, while we were busy sitting here, I received a call, like a message from a lady, man. It's a pensioner. She stays in Belhar. She said that she had to go to Tygerberg Hospital and they had to do a blood test on her. And then they told her that they don't do blood tests there anymore. She must go and pay for a blood test and then she must come back. She's a pensioner, so she actually had to use all the money to go and get the blood test. Is there a policy like that, Mr. Chair? Yeah, that's all.
Okay, Member Jacobs, we've got this last part of the pensioner that's been told to pay for a blood test because they're no longer doing blood tests there. We don't get you properly, Member Jacobs, on the first point of the blacklisted companies. Are you adamant in referring to TCC, or are you generalizing to want to try and find out which companies are being blacklisted by the province?
Yes, Chair. I'm saying we must be very, very careful when it comes to that. Hence, I'm saying the department must check all these companies because for me it's very strange when a company get blacklisted and then the company still gets a tender, year from Provincial. It's almost like the same what happened last year with infrastructure. One of the guys that was also implicated in state capture that also received a tender. You see, we don't want that kind of things, Mr. Chair. So it's important for the department to look into these kind of things because it gets serious at some times. Thank you.
Member Walters?
Chair, maybe just to look at a formulation, there is companies that were blacklisted doing business with government should be picked up by the due diligence of all tenders in the Western Cape.
Thank you, Member. Members, that brings us to the end of our sitting. And thank you very much for your inputs, and the meeting is adjourned.